So before we start, can any one of the students tell me what is spindle cell? Now, how do you define a spindle cell? Anybody? You must have attended 2 days back this polygonal cell rich lesions, right? So you know what is polygonal cell. Now tell me what is spindle cell.
Sir, elongated cells with tapered ends.
Very good, very good. And anything else?
The nucleus is elongated.
Yes, very good. So
It
cell
could be
has to be
tapered or blunt.
elongated. Yes, good. So cell has to be elongated, cell has to have tapered ends, cell has to have a nucleus which is also slightly elongated. It can be oval or elongated. And it has a length more than its width, but it is centrally wider. Okay. So if you look at some things like, you just by curiosity, if you put it in Google and what is spindle cell, define spindle cell, you get very interesting results. And so Cambridge Dictionary defines it as a long cell that is wide in the middle and narrow at each end. Uh, Google AI mode these days, everybody knows that, if you put anything, search in the Google, the first thing comes is a AI mode search result, and that search result gives like the definition as a long, slender, narrow cells often described as having fusiform or spindle shape, which are wider in the middle and tapered at the ends. Okay, so this is how it should look like. Cell with which has got tapered ends. It's elongated. It has nucleus also, which is elongated. It is wider in the middle and tapered at the both ends. Okay, that's how it should look like. There is a definition according to LibriPathology.org. That's a site where you can search for many things. So there it says that spindle cell is a cell that is a tapered at both ends. And then it says a taper means it gradually decreases towards one end. That can be seen in the cross section. Okay. So spindle cells can have pointy ends, typical for nerves. That's what it defines, and can have rounded ends. Those tapered ends can be pointy in something like you see in nerves, or those ends can be rounded, something like you see in a muscle or in a smooth muscle cell, which is a common example of what we see as a spindle cell. Okay. And then there is a definition. If you just put what defines spindle cell tumor, this National Cancer Institute, they have site, on that site, there is a definition given for spindle cell tumor. It says a type of tumor that contains cells called spindle cells based on their shape. And we know now what is the shape we are talking about, right? We have seen the different definition from different sites. And under a microscope, spindle cells looks long and slender. It also says that spindle cell tumors may be sarcomas or carcinomas. So when this topic was given to me that I have to give an approach to spindle cell tumor. Now there are so many soft tissue tumors or mesenchymal tumors which have got spindle cell morphology. And I don't think it is possible in a lecture for maybe hour or even for 2 hours to give you everything about all the spindle cell tumors. So I have given a cases which are something like how do you approach a spindle cell lesion at that particular site in that clinical setting, and what should be your differentials, whether it is a sarcoma, whether it's carcinoma, or whether it can be a something else altogether which has got a spindle cell morphology. That's what we are going to try to learn today. Okay, so this is a case one, which was a 62-year-old male, and this was like right vocal cord nodule. In fact, the ENT surgeon who removed it, he thought it is a vocal cord nodule. That means it must have been an exophytic lesion, and so he just removed it because uh, the patient usually presents with hoarseness also, change of voice and everything. So it must be causing problems. So he removed it, and that's what it came to us, and this is what was seen. So any student wants to describe this? Anybody? There are Shefali, Sagarika. Anybody? Sagar. Who wants to take this? Dr. Prabhu, who are the students with us?
Sir, we have Sagar, Shefali, and we have four,
So
five
Sagar,
students.
okay, so we'll give it to Sagar first. Sagar, can you describe this case?
Sagar,
Is
you
he
can
online?
unmute your.
Please, otherwise we won't be able to finish. Huh? Somebody has to describe it.
Sagarika,
So one student has to, describe it. Anyways, I don't know that they are not interested. I think nobody is speaking. Are they? Can they unmute themselves, Dr.
yes, sir,
Prabhu?
they can. They can
They
unmute,
can,
sir.
right? They can unmute. But
Sagarika, you are unmuted. You can describe it, please.
Hello,
Doc,
sir.
yes,
Sir,
Sagarika, come
sir,
describe, please.
as it is elderly, so we can think
Mhm.
of spindle cell squamous cell carcinoma,
No, you are
sarcoma.
not described, Dr. Sagarika. You have to describe it. That is a different thing. What you arrive at the differential or diagnosis. That's a completely last thing you should be doing. As a student, you should see what is it, what structure it is. Is there any normal tissue?
Sir,
If there is normal, what is the relation of normal tissue to abnormal? If there is any abnormal thing, what is an architecture of those? What are you going to see on low power? What are you going to see on high power? All those things I think you should describe and not to jump to the conclusion right away. You may be right, you may be wrong. I'm not saying anything about that. But this is what we are learning about an approach. So can you describe it, please? Now you have to describe this is a low power, scanner power. What do you see in this?
sir, it is looking like a well circumscribed area showing an ulcerated respiratory epithelium with many blood vessels in between,
Very
and
good,
it is
Anugrah.
very cellular looking area is there, in which on
Excellent.
this part I cannot fully appreciate the spindle cells.
Very good. So you are saying that this looks like a polypoidal lesion, right? It
Yes, sir.
has like a polyp-like thing where you don't see any surface epithelium. It looks like completely ulcerated, correct?
Yes, sir.
And then within subepithelium, you see something which is a cellular tumor-like lesion, right?
Yes, sir.
Which has got this different size vessels also, correct?
Yes, sir.
Yes.
Okay. This is another area from the surface. Again, same thing. You don't see any surface epithelium. It is completely ulcerated. Okay. And then underneath you see this tumor, which you rightly said. At this power, you don't want to venture and say what it is and what it looks like. Although maybe you can make out there are some fascicles like arrangement of the cells are there and looks rather cellular tumor, maybe a moderately cellular. Do you agree,
Yes, sir.
Anugrah?
Yes, sir.
Yeah,
Yes, sir.
very good. So let us go on to this may be a 10x or 5x. So now what do you want to now describe on this?
Sir, this is showing a cellular spindle cell lesion in which the spindle cells are arranged in fascicles. The cells are, sir, slight, mild pleomorphism, we can say.
Okay. So basically
And
at
also
this power, yeah,
there are areas of edema, also light pink areas,
okay,
edema in
okay,
between.
yes,
And proliferating blood vessels, I can also appreciate in between those
very,
tumor cells.
very good. So there is something like in some areas it looks eosinophilic, in some areas there is some myxoid change as well, right? And cells are arranged in fascicles. That much we can say on this power, right? Now, what about this? What more you want to say on this?
So this high power view is showing homomorphism of the cells. Again, the arrangement is of fascicles.
Very good.
Then, sir, we can say there are the cells. They have abundant eosinophilic cytoplasm in them.
Yes, very good. So we'll see some other thing now. Here, what do you want to say?
So this is marked pleomorphism appreciably in this
Yes.
area.
So there is a nuclear atypia you can see, right? The nuclear of different sizes and irregular nuclear membranes and everything. So nuclear atypia is definitely there, right? And most of these cells look like they are spindle, right? By
Yes,
definition, what you're seeing, they look like tapered at both ends, elongated with wider in the middle. And then nuclear also elongated or rather spindly looking, correct? That's why we
yes.
are saying these are spindle cells. Yes, very good. Anything else? This, what is this? I'm circling. You see this? My,
Mitosis.
yes, correct. It's a
Mito.
mitosis. Yeah. Yeah. Then this is more high power. So what you see here, same thing like you described earlier. You can see now there are nuclear pleomorphism there, the nuclear heavy nuclear borders. The chromatin is also hyperchromatic at places. It's like a very heterochromatic. At places you can see nucleoli, at places you can't see nucleoli. But definite feature here is a nuclear pleomorphism, right? And some
Yes,
maybe some inflammatory cells are admixed, some polymorphs, maybe some some lymphocytes, right?
yes.
So on the high power, you start to see this mitosis, right? This is a mitotic activity. So there is a mitotic activity also in this tumor, right? Some of these cells, like this cell which I'm pointing, it doesn't look more like a spindle cell, but it looks like maybe it has got some epithelioid features, right? So mostly tumor is spindle, but maybe there are some cells which are thrown in has some epithelioid-like features. Okay. Another area showing again same thing. This is fascicular arrangement. Nuclear atypia is quite marked by nuclear irregularity, nuclear hyperchromatic. Some giant cells, as somebody saying giant cells. That's correct. So you have a tumor which looks quite pleomorphic. Yeah. Okay.
Yes.
And again, some areas showing mitotic activity. Right. Okay. So what are your differentials on this? Do you think this is a benign lesion or a malignant lesion based
So
on your histology?
malignant lesion.
Yeah, so we'll most likely thinking of a malignant spindle cell lesion or a tumor because of its cellularity, because of its nuclear atypia, mitotic activity. All those are pointing towards something, and it is very rigid cellularity. It's not like loose cellularity is there, So it's not like something like a granulation tissue like thing. You don't see fascicles in those. Anything reactive conditions like an ulceration causing underlying reactive changes doesn't look like this. They are very haphazard, very hypocellular in a myxoid background, in a fibrinous background. You see a lot of inflammatory cells. So those are the reactive conditions. We here this completely looks different. So we'll definitely think of something like a neoplasm or a tumor, right? So then what are your differentials on this, Anugrah, about the tumors? What different tumors come to your mind, which you would like to rule out?
Sir, initially I thought sarcomatoid squamous cell carcinoma can be
Very good.
there. Then, sir, pleomorphic spindle cell type.
Type what? You're right. The first differential in this site, this is a upper aerodigestive mucosal site. When you see something like this, which looks like a tumor, which like malignant tumor which has got a spindle cell morphology, first thing you have to rule out is a spindle cell carcinoma, right? Because that is the most common spindle cell tumor you'll get in this site, a malignant tumor of spindle cell morphology. But you can have other differentials, right? Maybe you want to say if it is not carcinoma, then whether it is some sort of sarcoma, which is very rare, but it can happen. This is, and maybe it is a mucosal based melanoma which has got spindle cell morphology, right? Somebody has in a chat said fibrosarcoma. Okay, so fibrosarcoma usually is a more cellular, more bluish looking tumor, more fascicles, and they have herringbone pattern. So those usually fibrosarcomas looks quite different from this lesion, but yes, this you can have a differential of something of a spindle cell sarcoma also. So then how will you go about it, Anugrah?
Sir, I will go for IC.
Before IHC, do you want to do anything else just to be sure? What other things you would like to see whether
I
to
can
say
do
that it is a carcinoma?
I can do specials to differentiate between smooth muscle and fibroblastic component.
Okay, but those are not like very sacrosanct thing, no? Like it is not like specific. If this special strain is positive or this, that doesn't mean it is that only, you know. So it is special strains we hardly use for this purpose. Anything else you would have like to see which is missing in this sections or the images? If you are saying it is spindle cell carcinoma, right? That was your first differential, correct?
Yes, sir.
And spindle cell carcinoma of what type? Is a squamous type, right? Squamous
Yeah.
spindle cell carcinoma, correct? So
Yes,
from
sir.
where it arises then, Anugrah? From where the such tumor will arise? From surface epithelium, right?
Surface epithelium.
Which
Yes, sir.
should show dysplasia or squamous carcinoma in situ or frank epithelial looking squamous carcinoma, right? Do you
Yes,
agree
sir.
or you don't? Okay. Because there is surface ulceration, we are not able to see anything like that. We are not seeing any squamous epithelium. But I would have checked the entire areas of the biopsy or the excision and also done taken a serial dip cuts, you know, multiple sections to see if we can get some epithelial elements in those, you know, those which are look like a dysplastic squamous cells, dysplastic squamous cell nest or surface epithelium which is dysplasia, right? So that is the first thing you should do when you don't have IC. You will go and do that. Okay. But let
Yes.
us assume here I did the serial dip cuts and then one of the cuts showed this. Can you describe now in the center? What is this?
It's a necrosis.
This is not a necrosis.
Sir.
So these are like spindle cells here. Within this spindle cell proliferation, you see a nest of what kind of cells are these? Let us go and wrap up now. What are these cells? Somebody says polygonal cells. Very good. So she has picked up that polygonal cell. What kind of polygonal cells? Squishy is saying squamous. Yeah, she's absolutely right. So these squamoid or these look like a squamous cells, right? So this definitely they have a morphology which is polygonal, has got very eosinophilic cytoplasm and nuclei which are hyperchromatic, irregular. Some cells have, you know, this keratin-like trail also. So these are definitely squamous cells. They do look atypical or dysplastic. So within this tumor, you are seeing some island which has got very epithelial appearance, having a squamous morphology and looks like a dysplastic thing. Does it help in now making the diagnosis clear without doing IHC, Anugrah? Will that
Yes.
help you?
Yes.
Yes, this really helps. So, you know, as I told you, looking for some island like that or looking for a surface epithelium which has got dysplasia or squamous carcinoma inside too, or in an area which shows this epithelial morphology makes your life very easy and you can definitely say this is a sarcomatoid or spindle cell squamous carcinoma. Okay. But
Yes.
let's say you don't have this, you don't see anything, you have a small biopsy, you know, sometimes you get a punch biopsy and you may not be able to see this epithelial differentiation in the tumor. Then you will go and do the immunohistochemistry. So what immunochemistry you will do, Anugrah? You're absolutely right. You said that you want to do immunohistochemistry. But before that, one should actually look for epithelial differentiation and by doing serial dip cuts or studying more areas. Okay. So what immunohistochemistry markers you would like to do, Anugrah?
So for
You'll start with CK. You'll start with the cytokeratin, right?
yes, sir.
Pan-cytokeratin. Very good.
Pan-cytokeratin.
Pan-cytokeratin you want to do to see if there is any epithelial differentiation. And I have done in this case. Can you see the what is it? It is CK A1, A3. So it is a pan-cytokeratin which has got two antibodies, which are A1 and A3. And it is actually a cocktail. I will tell you that it contains not only low molecular weight cytokeratin, but even high molecular cytokeratin. So it covers a lot of cytokeratins. You have different type of cytokeratins. You must have heard CK5, 6, CK8 by 18, CK7, CK20, right? You must have heard this, right? So similarly, this cocktail antibody has got different type of cytokeratins, so that if you put at least some of those cytokeratins, we should be able to see in the cells so that the cells will be positive, right? So now you tell me, is it positive or is it negative, Anugrah, this CKA1, A3?
It is showing positivity, sir.
Yeah, good. So there are good number of cells here are showing positivity. You can say focal or patchy, whatever, but it's a nice positivity. You can even see the spindle nature of the cells in these positive cells, right?
Yes, sir.
The cells which are positive. So the definitely cells of interest, at least a proportion of cells of interest, which are spindle cells here, are positive for cytokeratin. That also confirms that it is a epithelial tumor which has got sarcomatous morphology showing epithelial differentiation. Okay. Another area of CKA1A3 also shows good number of cells showing cytokeratin expression. The area which is showing strong diffuse positivity here in a nest is actually surface squamous epithelium. Okay. But the spindle cells here, cells of interest are showing positivity. Okay. Now, since A1, A3, I was talking about A1 and A3 these are the two different antibodies which are there in this cocktail, and A1 actually detects high molecular weight cytokeratin, which are 10, 14, 15, and 16, and also detects low molecular weight cytokeratin, which is 19. And what does A3 does? A3 detects high molecular weight cytokeratin, which are 1, 2, 3, 4, 5, and 6, and also detects some low cytokeratins, low molecular weight cytokeratin, 6, 7, and 68. So that's why when you put this cocktail cytokeratin, or we call it a pan cytokeratin, whatever cytokeratins are present in these cells of interest, those will be marked. Okay. And it is a good way to know that this tumor has a epithelial differentiation. As opposed to that, there is other cytokeratin, pan cytokeratin are used in other labs, which is called cytokeratin MNF116. It also has got cocktail of high and low molecular cytokeratin. So high are CK5, 6, 8, 17, and low is 19. But can you see that the MNF116 cytokeratin cocktail antibody has got very few cytokeratins which are covered, as opposed to A1, A3. That's why it becomes very sensitive, A1, A3. So one should know which pan cytokeratin you have put. So let's say you have done, you think about such a tumor, you put cytokeratin, pan cytokeratin, come negative. Then you check what clone you have put, whether it is MNF116, then it doesn't cover all the cytokeratins. So it's a good idea to have another cytokeratin like A1, A3, which is covering more broad spectrum cytokeratin. Someone asked the question in the chat box that why not all cells are positive. It does happen. Some of the cells will lose this cytokeratin staining, and only very few cells will show. So that is also good enough, because within the cells of interest, even if some few cells show the positivity, that is a significant in itself, especially with this morphology. So moving ahead, I also did another cytokeratin, which is not covered in this cocktail, which is 6-8 by CK8 by 18, which also showed positivity in a proportion of this spindle cells. CK56 was negative, although it is covered in A1, A3. CK56 is negative. That tells us that these cells do not have CK56 in them. This protein is not present. That's why this CK56 antibody is negative. Similarly, EMA, which is epithelial membrane antigen, is also another marker which we use to say whether something has got a epithelial differentiation, which was also done and it is negative. So it can happen that EMA is negative, and EMA is a marker which is not just comes in epithelial cells, but it comes in so many other tumors also. So you should know. But we usually in combination, we always whenever we want to prove something is epithelial origin, we always do combination of CK-EMA. Just like we do a combination of CK7 and CK20, when you have a tumor which is like an adenocarcinoma, you want to put both antibodies together so that it gives you an idea what kind of tumor it is, especially in a metastatic setting. Let's say in a liver or lung, you want to know whether this tumor is from which site. So similarly, we always use CK in a combination human. It's a very good combination, if to say whether it has got epithelial differentiation or not. There are some tumors which are only CK positive but EMA negative. For example, germ cell tumor like yolk sac tumor, embryonal carcinoma. They will be CK positive but EMA negative. So in a setting, in a site where you have differential of germ cell tumor also, if you get CK positivity and EMA negativity, you are most likely dealing with something which is a germ cell tumor. Similarly, in gonads, in another lesion where you are suspecting whether it is sex called stromal tumor, and again you get some CK positivity but EMA negativity, your differential of thinking about sex called stromal is quite right, because again these tumors will have CK positivity and EMA negativity. So this combination does help in most of the things. So let's say if you're thinking about anything which is epithelial, but it is only EMA positive and CK negative. So that doesn't mean it is just an epithelial tumor or a tumor showing epithelial differentiation. So CK has to be positive, although there will be exception to this rule. But by and large, when we want to prove that some tumor which has got epithelial differentiation should have CK expression along with EMA. So if it has got only EMA and not CK, then you have to think and rule out other possibilities which are not like a epithelial, which is the tumor which are not having epithelial differentiation. Okay. When we are dealing with something like this and we think it is a spindle cell sarcoma, carcinoma at this site, which is a spindle cell squamous carcinoma, we also do marker called as P63, and it usually comes positive in some of these tumor cells. Here it was most of the cells were negative. Very occasional cells had positivity for P63, almost negligible and very difficult to say whether it's positive also. You may say occasional cells positive. And interestingly, these tumor cells also showed positivity for smooth muscle actin. So it does happen with these kind of tumors. The moment they become spindle, they have this epithelial mesenchymal transition where the cells which should have looked like epithelial now started looking like spindle cell, like a mesenchymal cell. They start to gain this different kind of antigens also, the proteins also. So that's why smooth muscle actin has come positive, and you should not be surprised that it is positive. And that doesn't mean that you should make a diagnosis of something like a smooth muscle tumor or some other tumor which expresses SMA. So it does happen in this kind of tumors. So if you have to enumerate salient features of this tumor, it is a spindle cell tumor. It shows nuclear reticulocyte mitosis. So that tells us that it is a malignant spindle cell tumor. And it had focal dysplasia squamous epithelium, which really helped. And the CK cytokeratin expression along with that has helped to come to the diagnosis that it is a sarcomatoid spindle cell carcinoma. We'll just quickly see another example of this, which I had not circulated. So this was a 64-year-old male. Now this is a biopsy from an exophytic polypoidal lesion in the buccal mesh. Interestingly, this type of tumors most often present like an exophytic or polypoidal lesion. Again, it looks like a surface epithelium is completely ulcerated here, which is covered with this ulceration is covered with ulcer slough, with fibrin and degenerating polymorphs and other cells. And then within subepithelium, you start to see something which looks like other cellular lesion. And also, even at this scanner, you can make out that there is probably there are some fascicles of these spindle cells. You move on to other areas. Again, there is a complete ulceration of overlying epithelium. And then there is some cellular areas in the subepithelium. These cellular areas have now you start to see they're quite rigid, like me. There is a lot of cellularity, moderate cellularity, and cells look like they're arranged in this vague fascicles here. Even at this power, you start to see that there are some cells which have got very large irregular nuclei. And you move on to more high power, you start to see that nuclei are now of very different sizes, very irregular. There is definite nuclear atypia here, nuclear pleomorphism. And stroma does have some inflammatory cells sprinkled, mostly polymorphonuclear leukocytes. And more high power field, this is 40x, you see more irregularity of the nuclear pleomorphism. Some cells may show some nucleoli also, but most of it is very heterochromatin, very irregular chromatin here, and nuclear borders are in nucleatine. And you see this tripolar atypical mitosis, which is very significant. So we know that we are dealing with something which is very malignant tumor, having a spindle cell morphology, having a lot of nuclear pleomorphism. And in one area, it also showed a surface epithelium which was intact. And this surface epithelium now looks quite different. It is, if you can compare this area with this area, here it looks like there is a lot of crowding of the nuclei, very haphazard, there loss of polarity. And at least at this low power, it seems like there is definite dysplasia in the squamous epithelium here. And you move on to high power and you start to see very irregular nuclei of very haphazardly arranged. That means you are saying it is loss of polarity because there is no proper maturation happening here, at least in 2/3 of the lower epithelium here. And as compared, you see here this area, this here you can see the maturation is still happening. So this is still quite better. Is maybe there is some ATP in the lower 1/3, but the upper 2/3 is showing maturation. And so the some areas definitely showing a lot of dysplastic changes here. Some areas showing maybe mild or maybe even benign changes. So this area again you can see mitotic activity, very irregular hyperchromatic nuclei reaching up to this the superficial layer also. And this is definitely dysplastic. It's almost amounting to squamous carcinoma inside too. Okay, severely dysplastic. If we compare this dysplastic area or squamous carcinoma inside too with another squamous epithelium, here you can see very nice maturation which is happening from basal layer till the middle layer and to the upper 1/3. So this is how your usual squamous epithelium should look like. And this is on the left side is something which is showing severe dysplasia. Almost you can call it severe dysplasia or squamous carcinoma inside. So this tumor had spindle cell morphology, very high grade looking tumor, and also had a surface epithelium showing dysplasia. So the diagnosis of sarcomatoid squamous cell carcinoma is very easy in this case. But if you still want to do marker and see what is happening with the markers, you will be surprised that in this tumor the CK cytokeratin was negative. This cytokeratin here is just a blush in the subepithelium. Surface epithelium is nicely cytokeratin A1, A3 positive, but the tumor cells are negative. There were some other areas were completely negative cytokeratin. So you are surprised now that even though there is a dysplasia in surface epithelium, there is a spindle cell proliferation below, which is malignant. And definitely it is arising from surface epithelium. So it is a spindle cell carcinoma, but the cytokeratins are negative. So it can happen like that. There are other cytokeratin I just put in cytokeratin 8 by 18, CK56. All cytokeratins are negative. EMA again is negative here. There is just some background staining there, but EMA is negative. There are some cells which are positive in EMA. Can anybody tell me what are these cells which are positive in EMA? The spindle cells are definitely negative, but there are some cells nicely positive. Can anybody type what are these cells? So this is when you see a stain, you just don't need to see what is happening there. You see cells of interest, which in the cells of interest whether it's positive or negative. But if it is positive in some other cells, you should try to see what type of cells are there. Some Cushy says endothelial cells, no Cushy endothelial cells don't mark with EMA as a rule. And Dr. Mugdha has rightly said these are plasma cells. So you should know that, the plasma cells also express EMA. So that is your internal control here, that your EMA stain has worked and it is positive. So one should know that, this EMA, even though it is epithelial membrane antigen, it is expressed in plasma cells. So this is how you should remember, because in some settings, this kind of aberrancy will help you in making a correct interpretation of the immunostain. P63 again, very nicely, strongly positive in that area which has got dysplasia, but in the spindle cell areas, very few cells are positive here. There are some other areas in which you can see P63 positive. Very few cells, maybe 5 to 10% cells are positive. So this tumor has all the CK negative, EMA negative, but some P63 is positive. So the combination of these three markers can also is very helpful. All three can be positive in maybe 60-70% of the cases. Only 6A CK positive will be up to some 50 to 60% of cases. And P60 will be positive in some 30-40% of the cases. So you really do it in a panel, in a combination, to make this diagnosis. You just don't do just one marker and say it comes negative, then you just move away from this diagnosis. At this site with this morphology, since your first differential is that, you have to do the panel. And if any one of these markers are positive, you are quite sure that you are making this diagnosis. Even if there is no squamous carcinoma in situ, or there is no dysplasia on the surface epithelium also, which can happen with a small biopsy, you'll still be able to make a confident diagnosis of sarcomatoid carcinoma. P67, you see the area which shows dysplasia or squamous carcinoma in situ is P67 almost going up to the surface. So it is very nice way of saying that this is completely dysplastic. And even in spindle cell, there is a lot of cells which are showing P67 expression as compared to the normal looking squamous epithelium, where the P67 is usually limited to basal cells, the basal layer. In the dysplasia, the P67 goes into the, depending upon the what type of dysplasia, mild, moderate to severe. In severe dysplasia, the P67 labeling index takes up all the layers of cells. So it's a good marker if you are confused whether it's dysplasia or reactive changes. So salient feature of this particular case was it is spindle cell tumor. There was marked nuclear atypia. You see mitosis. There is dysplastic squamous epithelium, which is like a squamous carcinoma anxiety. But CK was negative. Although P63 is focally positive, we can definitely confidently make a diagnosis of sarcomatoid or spindle cell carcinoma, which is a variant of squamous cell carcinomas. Very interestingly, that almost 90% of the laryngeal or pharyngeal spindle cell carcinomas present as a polypoid or exoptic mass presenting into the limbus. That's a usual way these spindle cell tumors or carcinomas will present. And in oral cavity, if you take example, which was the last case I showed you, which was also polypoidal. So the 50 to 60% of the tumors can be polypoidal or exhibiting. And as you know, these are biphasic tumors where you see some areas of conventional squamous cell carcinoma admixed with areas of spindle and pleomorphic tumor, which we have seen in these two examples. So in most of the areas, if you get in most of these tumors, up to I would say 60 to 70%, which is there in the literature, which says that if you see more sections, let's say you have got an excision, you see more sections or you do more serial dip cuts, you will be able to see some conventional squamous cell carcinoma or maybe a dysplasia in the overlying epithelium or some areas which are showing epithelial differentiation or epithelioid morphology along with this spindle or pleomorphic tumor. So, if you see all this, you can put everything together and make this diagnosis with confidence. And as I said, also you can do serial dip cuts to look for these epithelial areas. Sometimes spindle cells can be so bland and regular, and sometimes they can cause pleomorphic or multinuclear giant cells can also see. There can be very wide variety of artificial pattern, like fascicular, storiform, or lex-like or myxoid. But again, some people believe that spindle cell component is more haphazard than the true sarcoma. Like let's say somebody said fibrosarcoma. There it is very regimental fascicular pattern with herringbone-like areas. So that will be more regimental where you see in a true sarcomas. Whereas this here, the fascicles are not so regimental. That's what it is. And sometimes you have these transition type cells, which I showed in first case, the cells which are between the spindle and epithelial, and they have some epithelioid morphology. If those are there, that also helps to show you that, this can be a spindle cell squamous carcinoma. Usually when the tumor is polypoidal, what they say is that at the stalk of the polyp, usually you will see a frank squamous cell carcinoma of a conventional type or epithelial type. So it's a good idea that you see that area more carefully. Differential diagnosis at this site, like upper aerodigestive tract for spindle cell lesions, are quite a few. I mean, there are quite a few non-neoplastic or low-grade lesions. But the most common malignant spindle cell tumor at this site is spindle cell carcinoma. So you have to do all those things which I just enumerated to come to the diagnosis. And once you are ruled out that, then you need to think of all these other possibilities. About immunohistochemistry, you have to do the pan-cytokeratin markers along. You can be even A3 or CAM5.2. But if you see the different studies, you see the positivity of the cytokeratin. This first study, which is by Thompson et al., says only 26, which are done for a laryngeal tumors actually. Only 26% of them may express one of these A1, A3, or CAM5.2. And the range is up to 62% for all upper aerodigestic. You see, so cytokeratins can come only positive up to 62. So range is like from 26 to 62% of the cells of the cases. So it's really less. That's why you have to combine with EMA, wherein then you start to increase the sensitivity of your panel. And also you put some P63, that also will increase your sensitivity. So it's not like that all tumors will express cytokeratin. They will not. So you have to have everything in a combination. So we'll go to case number 2. This is 69-year-old male, biopsy from a lower rectal lesion. And interestingly, this lesion was also reaching up to the anorectal junction. So the gastroenterologist who did the scopy took the biopsy from the lesion in the rectum. So who wants to do this? Anybody? Students? Anugrah did. Now, anybody else want to do Shefali, Sagrika, Sagar? Anybody who is, I don't know who all are there, which I just forgot. There are 6 students are there, I think. Arpita,
Yes, sir.
yeah, can you please describe this?
Yes, sir. So we can see that the cells are arranged also here in a fascicular like pattern, and
So is it a rectal
different
mucosa or it's not a rectal mucosa? First thing you have to, once you see the biopsy, let's say now I have seen a rectal biopsy, then you should first thing see whether there is any rectal mucosa or not, right? Because
Yes,
this is
sir.
a endoscopic biopsy or a colonoscopic biopsy, so they are going to punch it out. So at least mucosa should be there. So can you see anything which is like a normal here? And what is the normal? What is abnormal? What's their relation? Can you describe like that?
So we can see some glands.
Very good. There are crypts, right?
Sorry, sir.
There are these crypts of rectal
Yes,
glands,
sir.
right? Yeah.
Yes, sir. Uh,
So those look normal, right?
yes, sir.
Okay. Then what you see?
Um, so we can see some uh, abnormal looking cells in the scanner view, although we'll have to go to a higher power for confirmation.
Okay.
Um,
So you
yes, sir.
think there are abnormal cells here, right? In between these
Yes,
glands.
in between the glands, and
They are infiltrating in between the glands.
yes, sir.
Correct. So you want to see another area. So what is this area showing now?
So we can see that the infiltrative pattern is retained in this.
So there is a tumor which is infiltrating, right?
Yes, sir.
With these small clusters, this
Yes,
different
sir.
type of clusters of cells, or maybe even fascicles like this, right?
Yes, sir.
Okay. So it's invading the mucosa, right?
Yes,
And
sir.
some mucosa. And this could be even a part of submucosa also possible. Now this is little higher power. Now what you see in this?
So some of the cells maybe are showing perinuclear vacuoles.
That we'll see a much higher power. No, this is like a middle, maybe 10, 20x. So here also you can see the cells of interest, which are these cells. Quite there is a definite pleomorphism, but they have spindle cell morphology. They are in clusters in some weak fascicles, which are invading
So
this stroma. Right, there is a stromal response as well. Correct.
yes, sir.
Very good. Another area showing same thing. There is some perivascular arrangement of the cells here, some fibrin around the vessel, but rest of the areas is showing the spindle cell. Again, here is more haphazard, but cells are definitely spindle because the nuclei are elongated.
Yes, sir.
Those are infiltrating into the stroma, inciting this stromal response. Okay, now describe on this high power, Arpita. You were trying to describe something to me. What do you see here?
So we can see good amount of nuclear atypia,
Very good.
hyperchromatic nuclei, and NC ratio is disturbed, sir.
Okay.
Sir, maybe the perinuclear vacuolation is more clear over here.
Maybe, yes. Maybe these cells show this large eosinophilic nuclei, right? Maybe there is
Yes,
some
sir.
perinuclear, whatever you want to call
Yeah.
acculation. But as you rightly said, the tumor cells show a lot of nuclear pleomorphism. There is some, you see this, what is this? I'm circling.
So this one looked like a mitosis.
Yes, so there are mitotic figures. There are 1, 2, 3 at least here within this small area. And here
Yes,
also
sir.
one. So it is very mitotically active, showing a lot
Yes,
of nuclear pleomorphism. This tumor has a spindle cell morphology. Yes, brisk mitotic activity, we like to call it, right?
yes, sir.
Very good. This is more high power. See now. Same thing what you described, sort of nuclear pleomorphism. There is heterochromatic in associated nucleoli in some cases,
Yes, sir.
mitotically active. Other areas also there are mitosis and cells showing nuclear atypia. Correct?
Yes, sir.
Same thing everywhere.
Yes,
And
sir.
again, this area shows spindle cells which are infiltrating muscular. Somebody says the infiltrating tumor with whatever. Some cells do have epithelial morphology. I agree. So most of the tumor has it's spindle cell morphology, but some cells do have epithelial morphology. I completely agree. And this is what the tumor is. So now, what is your differential, Arpita, on this morphology in this site? So whenever you are giving differential, now you should always keep in mind what is my site, what is this
Yes, sir.
biopsy site, and then
Sir,
accordingly what is the morphology you see on histology, and then you try to frame your differentials. Some Khushi says gist and leiomyosarcoma. That's a good
yes, sir.
differential, Khushi. Thank you. So what are your differentials, Arpita?
Sir, I was
Yes,
about to say the
Wong
same
said
because
gist. Very
it's a
good. Yeah.
rectal
So say
biopsy.
you can say it. You can say it for everybody. What are your differentials? Please tell me.
Sir, the first one would be just only because the region is the rectal region.
Very good.
And so second could be leiomyoma or leiomyosarcoma.
Leiomyosarcoma. Very good.
Yes, sir. Sir,
Why leiomyoma? It is a malignant, right? You
yes,
you
sir.
have any doubt that this is benign? No.
No,
You
sir.
have seen a lot of mitosis, a lot of nuclear pleomorphism. So
Yes,
unlikely
sir.
this is benign. So it is something which is malignant, which
So
has got
these were my
spindle
two
cell
differentials when
morphology.
I was looking at the case.
Very good. Any other differential anybody has got? Can you get sarcomatoid carcinoma in this area?
Sarcomatoid,
Let's say especially something which is arising in anal canal and then secondarily infiltrating into the rectum. Can it happen? Because anal canal
yes,
itself is lined by squamous epithelium and
yes,
there you
sir.
can have squamous spindle cell carcinoma, right? Yeah,
Yes, sir.
Manisha
Yes,
says
sir.
that. Very good. She's right. Mugdha has another differential. She says melanoma. So can it be melanoma also, Arpita?
Sir, I'm not sure about melanoma, sir.
Can it occur at this site?
So melanoma, I've usually heard occurring on the surface epithelium, like on the skin, or it can, sir, metastasize to any place.
Correct, very good. It can metastasize any place, yes. But let's say it can be coming from anal canals, surface epithelium, like squamous epithelium, and then invading into the rectum. Can it be possible to have melanoma like that?
Uh,
And can melanoma or spindle cell morphology? There are two things here. Akash is saying colorectal carcinoma. I mean, colorectal carcinoma, by and large, is more epithelioid tumor. Usually don't get sarcomatoid, but that can be a very, very, very rare possibility. We'll have to do the markers to prove that. But yes, melanoma can be a possibility, very good possibility, because although most of the melanomas have epithelioid morphology or plasmacytoid morphology, some of the melanomas can have spindle cell morphology, and those can actually come from anal canal and invade into the rectum. Okay, so it is a possibility. So basically, we have differentials of GIST. Now, to say GIST just on histology to give a pointers, GIST usually doesn't have this much of atypia, this much of mitotic activity. You know how mitotic activity in GIST actually is calculated per how many power fields, high power fields. Arpita, like for any other tumor, we say mitotic activity per 10 high power fields.
Yes, sir.
Yes, Akash, Kushi, Manisha, all are saying 50. Vaishnavi is also saying 50, and they're all are right. Because this tumor, just has got so few mitosis, we actually have to go up to 550 high power field to look for mitosis.
Okay,
So,
sir.
but this tumor has got a lot of mitosis. It has got a
Yes,
lot of
sir.
nuclear pleomorphism, which is usually not a feature of a GIST, unless something which is very high grade GIST, which is very, very rare possibility, or there is something called a de-differentiation in the GIST, which are treated GIST can have very ugly looking morphology. Those are very rare conditions or rare tumors. By and large, the usual GIST do not have such a pleomorphic, highly mitotically active morphology. Okay. But still, okay, we'll keep because of the site, because of it is GI tract. GIST is a possibility. Somebody said sarcomas is a possibility. It's a very good thought. It can be any sarcoma, can occur at this site. It can be carcinoma, sarcomatoid may be coming from anal canal infiltrating into the rectum, or it can be a melanoma also, which is also a good thought. So what markers you will start with, Kushi? So to prove, let's say, a carcinoma, what markers you have seen now in two cases, what markers we do to prove something is carcinoma or has got epithelial differentiation? Arpita, you will do what? Sorry, for carcinoma, I'm saying you'll do cytokeratins, right?
Yes, sir.
Yes. So, okay, so these were the differential we discussed. So cytokeratin, Dia is absolutely right. Some area that this epithelioid morphology, and somebody nicely pointed out some area that nice, so this epithelioid morphology along the spindle and very prominent nucleoli. Yes, Vint is also right. He is also right. He says cytokeratin. So yes, we'll start with doing dog 16 CK117. Sorry, sir, CKIT or CD117. Everything we'll have to do. So let's see. Cytokeratin, A1, A3 is positive or negative? Arpita, you just have to say negative or positive. In the cells of interest, what are the cells of interest? Are these cells which are infiltrating in between? Negative, correct? So only these glands which are crypts which are positive, the normal rectal glands, right? So cytokeratin is negative. This is EMA. I told you we always do CK EMA as a pair. EMA is positive in the glands, the surface epithelium, there are always apical areas which are taken up by EMA, which is, you just remember when in CK everything is taken up. But in EMA, it is interestingly only apical membrane is taken of the cells in the glands. That's how CK looks. Here, CK looks EMA looks positive or negative. Somebody said blush, and I will agree with that person. It does look like a blush. I'm not very sure if it is weakly positive or blush, maybe like that, but it's not very nicely positive. So I would take it as a negative. Then for melanoma, we do markers like this HMB45 is a marker for melanoma, correct? So it is positive or negative?
Negative.
Negative, very good. Yes, all are saying negative. Thank you. You are absolutely right. Melane, negative or positive?
Negative.
Negative, very good. So it is definitely negative. So there are two markers. You just don't stop at doing one marker. Anything you want to say, any differentiation, let's say site epithelial differentiation. You don't just stop and only CK. Then you do CK with EMA, pancytokeratin or EMA, both together. If those are also negative, you do CK8 by 18, CK56, other cytokeratin, high molecular cytokeratin. You just don't stop at one marker. You similarly to say anything is melanocytic or melanoma, you do HM45, but also you do other markers also. Just because HM45 negative, you don't rule out possibility of melanoma because you can have other markers which are positive, like melanin. So melanin is a negative here. So now two markers are negative, but I still again put third marker. What is this marker is MITF, it's written, it's a microphthalmia transcription factor, and it also comes positive in melanoma. So I have done three markers for melanoma. All three are negative. So now how to proceed? Can it be still melanoma, Arpita, or anybody from
Unlikely,
the
sir.
audience?
Less likely.
Unlikely, less likely. Okay, let's see. Anybody else want to take a call? Yes, Vaishnavi says a melanotic melanoma. Can it be negative? Kushi, I don't have PREM. I don't have experience with PREM, but yes, PREM can be positive. Leiomyosarcoma, SMA was negative, Desmin was negative. I don't have pictures, but it was negative for SMA and Desmin. So that rules out leiomyosarcoma. It was negative for c-KIT and DOG1. So that ruled out a possibility of GIST also. But somebody said a melanotic melanoma, and she's right. Melanotic melanoma or melanoma having spindle cell morphology can be negative for these three markers, which we do: melane, METF, and tyrosinase. I have not done the tyrosinase. No. So you can do tyrosinase also and HMB45. So three markers which we do usually regularly, which are there in my lab, all are negative. So S100 also, this area is definitely negative, right? So if it is melanoma, you usually expect S. Yes, SOX10 is a very good marker. So I'm going to come to that DR. So let's see. S100 was negative, but in some area, CD30. Maha is saying CD30. Why CD30? Are you thinking that this could be a anaplastic large cell lymphoma showing spindle cell morphology? That's why you are saying 30. Suspected anaplastic. Oh, okay. Yeah, and that's a good thought, Maha. Very good thought. But no, I didn't do the 30. Actually, I'll come to it why I didn't do 30. Actually, whatever markers I did, I got the results. So let's see. CD34, no, I didn't do CD34. No. Okay. So now what? But you see, in some area, S100 was actually positive. You see the S100. So the majority of areas were negative, which I showed the first image was majority was negative. But in one area, it was nicely positive, very nice. And S100 is not only in cytoplasm, but also in nuclei. So whenever you are interpreting S100 protein for a tumor which you are suspecting a melanocytic tumor or a nerve sheath tumor, you have to see whether it is a nuclear positivity. Unless it is nuclear positivity, you don't take it as a positive. Okay? Because cytoplasmic positivity can come in some tumors like histocytic tumors, can have cytoplasmic positivity, but not a nuclear positivity. The moment you get both nuclear and cytoplasmic, that means you are either dealing with something which is of a neural origin or a melanocytic. Because our differential was melanoma here, this positivity is a significant positivity. So S100 is positivity, but someone has rightly said the SOX10 is also very good marker. So I did SOX10. Again, SOX10 is good for neural or melanocytic tumors. Okay. And this is a SOX10. This is from a low power. You can see brilliantly positive cells. These are almost all cells are positive. For SOX10 is a very good marker. Another area showing nice SOX10 positive. So with HM45 negative, melanin METF negative, but S100 focal, but nicely positive, and SOX10 diffusely positive. Can it be melanoma? Arpita, anybody?
Yes, yes, sir.
Yes,
Now it's looking
exactly.
like it
It can
is.
still be a melanoma and it can have this kind of morphology and can only show these two markers, not the other markers. So it is actually it is a melanotic melanoma having a spindle cell morphology. Okay. If
Yes,
somebody thought why it is so strongly as a Stockton positive, S and it is very locally, can it be a MPNST? What is MPNST? Malignant peripheral
very
nerve
good.
sheath tumor. We can have also this, morphology. So I did S3K27 ME3, which was retained. Usually they show loss, not in all cases, but at least 50% or maybe more can show this histone molecule loss, and that also confirms whether it is MPNST. But at this site, with this morphology, this is definitely a spindle cell melanoma and not the malignant peripheral nerve sheath tumor, even though it is a melanoma. Okay. So it is actually, if you enumerate the salient feature of this tumor, it is a spindle cell tumor, shows marked nuclear atypia. There are nucleoli present, which is a very good clue. There is this mitotic activity. There is nice S100 and diffuse SOX10 positivity, and it was negative for HM45 melanine emitter and CK. So it ruled out the sarcomatoid carcinomas. We had ruled out, I had not shown you those markers, but ruled out the other markers of sarcoma, and it is definitely a spindle cell melanoma. If you take the combination of this SOX10 and S100 is very interesting actually. If you see both positive, SOX10 and S100 are these tumors, which are these peripheral nerve sheath tumors, melanocytic tumors, or a sarcoma showing melanocytic differentiation, like what? Like a clear cell sarcoma of the soft tissue. So these tumors, only these tumors are having both positive, S100 and SOX10. When there is SOX10 negative and only S100 positive, the list is very large, including kinase altered neoplasm, which is new thing. Biophonetic sinonasal sarcoma in the sinonasal cavity, ossifying fibromyxar tumor in the soft tissue, myopitheliomas of the soft tissues. And then there are other tumors like histocytic sarcoma, Rosette Hoffman are, even though these are histocytic tumor, they are S100 positive but SOX10 negative. And interestingly, in histocytic sarcoma and Rosette Hoffman disease, the S100 positivity will be only in cytoplasm and not in nucleus. Okay, so that's a good clue. SOX10 positive, but S100 negative tumors are actually triple negative breast cancer. Triple negative carcinomas of the breast. If you, let's say, in a metastatic setting, you want to prove it is a carcinoma coming from breast, you do GATA3, and GATA3 is negative. Often these triple negative breast cancers are GATA3 negative, a marker which we so often use to prove that something is coming from breast. But surprisingly, in triple negative tumors, that comes negative, then you can do a SOX10. And SOX10, if comes positive, you can still say it is coming from breast. Although the much better marker now for this cancer, triple negative cancer, is now what is called a TRPS1. If you have that, then you can do that marker also. But if you don't have, SOX10 may help you in at least in good proportion of cases. So this was a spindle cell melanoma. I'll just quickly go through another case like this. This is a 71-year-old female. This site is Kaposi sarcomas can occur in any GI tract. Yes. So I think that's why I think you are asking for CD34. But because I had got this SOX10 and S100, I didn't think of that possibility. Although, yes, that can be thought of, although you don't get that much of nuclear pleomorphism like what you see in these. They are usually very subtle spindle cell proliferation with slit-like areas and RBCs thrown in there. So yes, but I think your differential, I would take that. You're right that you can think of composite sarcomas. Okay, quickly going on to this case. Actually, in between, people are writing, so I'm trying to address those issues also. That's why I get waylaid from the whatever I'm talking actually. Anyway, so this case is actually, she is a 71-year-old female, and this lesion is actually from the anterior vaginal wall. And there was a significant history that some lump was removed from this the same site 2 months back, and details were not available. As usual, sometimes gynecologists throw it without bothering. It must be cyst or something they think, and probably that's what happened because I tried to ask them, and they say so there's no details, and that we don't have histopathology. It does happen, which is sad, but that has happened in this case. And now here you see There is squamous epithelium, which is good, nicely glycogenated squamous epithelium for this site. Looks benign, no dysplasia. Nothing can you see in this subepithelium here, apart from this thick wall vessel, some fibrosis. But in some area, you start to see this spindle cell proliferation, rather bland looking, at least on this power, and very haphazardly arranged, maybe in some weak, short, fascicle, but haphazardly, the spindle cell proliferation here at this area, which I am pointing with my laser pointer. Okay. Another area again had this very subtle spindle cell proliferation here, infiltrating into the stroma. And not very cellular, it is mildly cellular lesion at least. And hard power, you start to see there is some nuclear atypia, some nuclear variations can be seen. Again, these cells are very haphazardly infiltrating into the stroma. But this is the area of interest. This is the area of, these are the cells of interest here. What are these cells would be the, what we would like to know at least. And on more high power, you start to see there is definite nuclear atypia here, hyperchromasia of the chromatin of the nuclei here, and irregularity, more haphazardly arranged. And there is nuclear variation. In one area, you see this nesting of the cells. There are two nest-like cells, same cells. They have this nesting. And then there are other cells which are showing nuclear atypia. They are infiltrating more haphazardly, maybe little spindly, short fascicle probably, but they have spindle cell morphology. Here it is little ovoid or epithelioid, maybe. And again, more high power P40X, you see hyperchromasia, irregularity of nuclear membranes. So even though on a low power, it looked like there is nothing happening much, very hypocellular, bland looking, but at high power, you can make out it does have a nuclear atypia, at least moderate nuclear atypia, even though it is hypocellular. So you really want to know what has happened because it has recurred within 2 months. So you suspect it is not just any benign condition or intermediate malignancy. It is rather behaving in a malignant fashion. So you really want to make sure what we are dealing with here. Again, I had some differentials of I'm going to show you the only markers which came positive. S100. See, noise, strong, diffuse positivity. As I mentioned, it is nuclear also and cytoplasmic. Both can be neural, can be melanocytic. Nice. Again, high power showing same thing. Nuclei also taken up and the cytoplasm. SOX10 is also brilliantly positive, strong and diffuse. So only two tumors can, I mean, the most tumors showing S100 such a brilliant positive are usually melanomas, Even the malignant or benign peripheral nerve tumors. The malignant peripheral nerve tumor, which is we call MPNST, are usually not so strong diffuse S100 positive. You will only have patchy positivity. That is also one clue that you are dealing something which is like malignant peripheral nerve tumor and not melanoma. Melanoma, whatever morphology, usually morphology, you get strong and diffuse staining of S100 in most cases. Some cases can be exception, but that's the clue also. So both are nicely positive here. So I'm thinking more in terms of melanocytic rather than nerve like tumors, nerve tumor. And then you throw in other markers to prove whether it's melanocytic. HM45 is positive. Good proportion of cells are positive. Melan is diffusely positive. You can make out some nicely. There are two markers which are positive. SMA was negative. Desmin was negative. You do in a panel, when you think of any spindle cell tumor at any site, let's say in a soft tissues or anything, you usually like to do four. At least I start with four markers because I'm thinking it is, let's say, a mesenchymal tumor. And not that areas where, mucosal site or other areas where there are other differential like carcinomas or melanomas or other, maybe cyst and other differentials. In this setting, if you think of soft tissue, then I do four markers, SMA, Desmin. Those will rule out or rather prove you whether it is of muscle origin, be it fibroblastic or rhabdomyosarcomas or other tumors. You do CD34, 34 comes not only even in endothelial cells or vascular tumors, but also in fibroblastic cells, fibroblastic tumors. So 34 is a good marker. And you do S100 because S100 will prove whether it is of neural origin or not. So these usually cover, these are like a broad spectrum markers for something which you think is a spindle cell tumor of the soft tissues. So that's a good idea to do if you're thinking. In this case, I had done other markers, but I'm not showing the pictures here, but SMA does mean 34 all were negative, S100 was positive as I mentioned. And in focal area, there was this melanin-like pigment also, which had given me clue that I am not dealing just with some spindle cell lesion which is not melanocytic, but probably melanocytic or maybe as melanoma to save it because it has recurred so within a short period of time. So if I had to enumerate what are the features I saw, it was spindle cell tumor, had a minimal to moderate nuclear atypia, nuclear layer not seen, but and mitotic active was also in conspicuous, but melanin pigment was seen. And what was there was very conspicuously was S100 and SOX10 strong positivity along with agent 45 melanin positive. So I made this diagnosis that this is again is a spindle cell melanoma. Okay, so in a mucosal sites when melanoma occurs, there are different sites because the melanocytes can be seen in mucosa in this different setting. Like in oral cavity, you may see melanocytes in epithelium, esophagus, rectum and anal canal, nasal cavity and paranasal sinuses. You can also see in larynx, vagina and cervix. So this was a vaginal nodule, and that's why you can have melanomas also occurring at this site. So something about mucosal melanomas because we saw two cases now. One is in rectum, probably arising from anal canal, that melanoma, which was again had spindle cell morphology, and one we saw in vagina. So if you have to tell you something more about sites of mucosal melanoma, in head and neck region, in a decreasing order of prevalency, it occurs like most often it will occur in nasal cavity and paranasal sinuses. And of all the mucosal sites, 23% of the actual melanomas will occur in nasal cavity and paranasal sinus. 50% of them occur in oral cavity, that means in buccal mucosa, tongue, or lip, that kind of thing. And if you take only head and neck cancer, then 80% of head and neck mucosal melanomas involve nasal septum, nasal cavity, or a nasal septum, or maxillary sinus. And interestingly, in oral cavity, if there you see any melanoma, those are usually occur in maxillary gingiva or palate, not usually in the mandibular gingiva or the lips or the floor of mouth. Usually, this is how melanoma occurs. The other areas you can have in larynx and esophagus also melanomas. You can have in lower GI tract like rectum and anal canal also. Almost all of the mucosal melanomas, 26% of them occur actually in the rectum and anal canal. So it is more majority than occur in that site. You can also have sites like vagina and cervix having melanomas, urological tract like urothelial tract can have melanomas, and other site like conjunctiva can also have mucosal site melanomas. These are very rare type of melanomas occurring at mucosal sites. I mean, most of the melanomas will occur in the skin, right? So mucosal site melanomas vary from different studies from 0.8 to 3.7 in of the all melanomas. And these are more aggressive than the cutaneous type of melanoma. The overall survival or the 5-year survival is actually less than 25%. And interestingly, or it's not so interesting, but the bad fact is that 20% of this patient will have metastasis at the time of diagnosis itself. So you now know that they are very, although they are rare, but they are very aggressive. It's our prerogative to make the diagnosis right because these days you have very good treatment for melanoma. You have the immunotherapies. There are some anti-BRAF agents or MEK inhibitors, and all those are given. So it's very important for us to think about it um, and make that diagnosis properly. Histologically, melanomas like in cutaneous melanomas here also in mucosal sites can have spindle, epithelioid, pleomorphic to rhabdoid, plasmacytoid or undifferentiated morphology. The clues are, more prominent nucleoli, mitotic figures. Those are the clues. And interestingly, 50% of mucosal melanomas are actually a melanotic. So you have more problems in making the differential diagnosis and RN diagnosis, but you have to have a high suspicion for these tumors at these sites. The melanomas and spindle cell morphology are actually of two types. I'm not going to go into details. Especially at cutaneous sites, you have spindle cell melanoma and desmoplastic melanoma. Yes, these tumors can have inconspicuous nucleoli also. More the melanomas Somebody asked the question whether spindle cell melanomas can have inconspicuous nucleoli. Yes, they can be inconspicuous. Mostly the tumors which have got more epithelioid morphology or rhabdoid or plasmacytoid morphology, they will show you nice nucleoli as opposed to more spindle. That's why they are difficult to diagnose. And desmoplastic are more difficult to diagnose because they are very hypocellular, has got a lot of collagen. But these are the two types which usually occur at the cutaneous site. You can have these differential when a melanoma shows spindle morphology. One is spindle cell melanoma, other is desmoplastic melanoma. And interestingly, the desmoplastic type may not even express the other, melanocytic markers like melanin, HMB45. So that and they only will express S100 or SOX10. So the diagnosis becomes very difficult. You again have to have very high suspicion for this type of tumors. Some people have come up with this algorithm like how when you say spindle cell versus desmoplastic, so you do first marker melanin. If melanin is positive, it is spindle cell melanoma. If melanin is negative, then only S100 SOX10 positive, then it could be desmoplastic melanoma if you prove that there is a lot of collagen by doing trichome in that. Okay, so that thing. Other thing interesting is about the markers in this conventional melanoma versus spindle and desmoplastic. If you see S100 and SOX10 comes positive in most of these tumors in any morphology, conventional spindle or desmoplastic. But you move towards melanin, HM45 and META, the percentage of positivity in spindle cell and desmoplastic starts to decrease rapidly. There are very few of the desmoplastic melanomas will have melanin, HM45, META. Oh, very interestingly, MUM1 is a marker, what we say is a multiple myeloma 1 marker, which we do for plasma cells. Is interestingly positive in almost 92% of the conventional melanomas. So you just have to remember sometimes you can use some other markers also to prove like this is of different area. Even though we use it for lymphomas, you can use it in melanomas to prove it is a melanoma. BRAF antibody if you have, conventional melanomas up to 50% are positive. Spindle cells can be 31% and dysplastic are only 5%. So that's also challenged by doing antibody. So I thought it's important for you to know. We'll move to case number 3. I think we still have 3 more cases. So we'll go a little faster from now on because we have already more than 1 hour into the discussion. Case 3, she is a 65-year-old lady having a left breast lump, which was of a size 3.5 centimeter. And with the circulation of these slides, you can make out that these are actually cores of the biopsy. That means it is something like a UHG guided biopsy, which is a true cut biopsy, which is done. Who wants to do this? Anybody else? Arpita has done. Anugrah has done. Anybody else? Sagarika or Sagar or somebody else wants to do this?
So, so the section studied from the core biopsy of the breast tissue shows fatty tissue along with stroma. The stromal cellularity is increased.
Very good.
I can't describe the cells exactly from this foci.
Anything normal or something which tells you it is a breast?
Sir, in the center there's a like ductal
Correct.
type.
Ductal proliferation or duct-like.
Ductal proliferation is there.
Very good. Okay. So you want to go now maybe a different power. Okay. So this is 10x or 20x. Now you want to describe?
So the stromal cells, they are arranged in vague fascicular arrangement is there.
Yeah. Yes. Correct. There is some vague fascicular.
Stroma is myxoid at places.
Myxoid at places collagenized, right?
Collagenized, yes, sir.
Correct. Okay. And looks like a mildly to moderately cellular. In some areas it is very mildly. In some areas it is moderately, maybe more cellular. Correct. It has got heterogeneous cellularity. Okay. Very good.
Yes.
This is another area. So this is what I was saying. Whether you see anything to say it is a breast, then you can see there is some duct-like structure. Maybe there is something which is happening within the duct, some
Yes, sir.
proliferation, some alienation between. But this is the area of interest outside it, which you rightly said. There is some spindle cell proliferation within this collagenized or myxoid stroma, hypercellular areas. What can you
Yes.
describe here?
So the cells, the nuclei looks a little hyperchromatic.
Yes.
Uh,
So there is a
and
nuclear variation, right? At least
yes,
mild to moderate
geomorphism is there. Yes.
Okay. And this power, I don't think we are able to see any mitosis, correct?
Yes, sir.
Yeah. So let us see here. What can you describe?
So again, the same nuclear ATPI is seen, hyperchromatism.
Yes.
Then
So
at 1 or
chromatin is
2
actually more heterochromatic. In places it is more hyperchromatic. In places it is more open or fine chromatin. In some
yes,
places it is vesicular also with nucleolus. Can you see
yes, sir.
here? Yeah. So it's
Yes, sir.
quite different. Yeah. Somebody says there is internuclear inclusion. Maybe there is some internuclear inclusion. And there is this eosinophilic cytoplasm. And some
Yes,
inflammatory cells are also sprinkled in between, right?
yes, sir.
So there is a spindle cell proliferation showing mild to moderate nuclear atypia in a collagenized and myxoid background, correct?
Yes, sir.
Yeah. Other area showing same thing, like there is good nuclear or nuclear pleomorphism here, very hyperchromatic in nucleic, and some are not that much. And again collagenous stroma with some myxoid areas.
Myxoid.
In areas which are more cellular, less cellular. Okay. Now
Yes,
coming
sir.
to this area, which you said rightly that there is some duct with some ductal proliferation. It looks like something which is sclerosing here, right? There are
Yes, sir.
some ducts here and then some sclerosing stroma here. Maybe something which is intraductal proliferation, which has scleros. Maybe could be a. Somebody said DCIS. It doesn't look like DCIS to me because in DCIS, what you see here, in a DCIS, you'll have very uniform cell morphology. Okay,
Yes, sir.
this is not a uniform cell morphology. Then you'll have very nicely punched out areas which are not there in this to say a DCIS. They're not like, although it is not a high power, but they're not like cells which are showing, although they're maybe uniform, but will have nice enlarged nuclei with nucleoli like that. If it is high grade, low grade will not have nucleoli, but they will look similar to each other like the monomorphism. That's the how we say DCIS versus just an ductal hyperplasia. Here the cells are very haphazardly arranged. And some sclerosis there, then if cells are don't look like similar to each other. So unlikely this is the DCIS. It may be something like intraductal papillary lesion which has sclerosis. That's what I feel because this entire thing looks like the same thing. Although here you see more of a ductal proliferation. Okay, high power. Sorry, high power is there. Okay, so here again it can't be a DCIS because you don't see nice punched out areas. The cells are of very different sizes. There is some very crowding of the cells. Here it is less crowding. Some sclerosis. Usually in DCIS, if it is of a low nuclear grade, you have very monomorphic cells filling the ducts, and you will have very regular punched out areas. So that helps to make the diagnosis of DCIS. This certainly is not a high grade DCIS because high grade DCIS will have more large cells with high NC ratio nucleoli. So this does look like some sclerosed lesion within the duct, maybe a papilloma. But surrounding it, there is this spindle cell proliferation having this RTPI. So what are your differentials, Shefali? I think Shefali was describing, right?
Yes, sir.
Very good, nicely described. So tell me now, what are your differentials on this case?
So
Now
could be
you have to give the differential based on the site. That's very important. Although it is spindle cell lesion, what is the site? Yes.
so could be metaplastic spindle cell carcinoma of breast.
Very good. Very good. Yeah, that is one. What else?
Then primary sarcoma, myofibroblastoma, if we are considering malignant. If we are considering benign, but it looks malignant.
It doesn't look benign. No? Myofibroblastomas are usually very well
Yes.
circumscribed lesions. they have different morphology, have more epithelioid, but can have spindle cells, but both spindle and epithelioid. They are usually very monotonous looking, not such thing. Somebody says angiosarcoma. Can it be angiosarcoma?
No.
Angiosarcomas, usually if you have very high grade angiosarcomas, you will not have maybe vascular vasoformation or like a vascular channels. This doesn't look like that kind of high grade angiosarcoma. The low grade angiosarcoma will definitely show you vascular channels, the anastomosing vascular channels which are lined by very
Sir, can
malignant
this be
looking
malignant?
endothelial
Phyllodes.
pillows. So yes, very good. It can, because this is a true cut and phyllodes is a possibility. So for a phyllodes, to make a diagnosis on true cut, one thing is you should be able to say whether it has got any morphology like fibroepithelial tumor. Now, how do you say fibroepithelial tumor on biopsy? You need to see whether there is something like a intracanalicular growth pattern or a leaf-like pattern, what you see,
Yes.
which is not seen in this case. You see mostly this spindle cell proliferation, which is infiltrating into the fat, infiltrating around that ductal proliferation. And you don't see any intracanalicular pattern or exaggerated intracanalicular pattern, which is also we say leaf-like pattern, which you see in the phyllodes, which is not seen in this biopsy. But yes, you may have hit an area which doesn't have this morphology, because you can have a very heterogeneous morphology in phyllodes tumors. So you may have this biopsy may have come from an area where you don't have that typical fibroepithelial tumor-like morphology or a phyllodes-like morphology. So I completely agree with you. Phyllodes tumor is still a differential here, which is we would think of malignant phyllodes. Yes, right. Somebody says, Manisha says, you may not see that in biopsy. Yes, you may not see in biopsies. So that is there. So one is a metaplastic carcinoma, very good thought, because we are thinking it looks malignant. Although some may say it could be a benign condition like, let's say, nodular fasciitis. I mean, that can happen. Nodular fasciitis can have something like this, but they are more like a myxoid areas, more have a stellate cells, myofibroblasts, not just spindly cells like this. And they usually have like RBCs, which are there sprinkled, more tissue culture like, the morphology of that lesion, which is not seen here. So I wouldn't go into that benign differential like nodular fasciitis or something like that. But yes, definitely metaplastic carcinoma, because it has a metaplastic, the spindle cell morphology, and whether it is a part of an area which is of a phyllodes tumor, probably malignant phyllodes tumor, is also definite a possibility. Somebody said whether can it be an invasive lobular carcinoma. I don't think it is an invasive lobular, because you don't see epithelioid morphology. Usually in lobular carcinoma, you have cells having epithelioid morphology with round nuclei. They can be in single cells or they can be in nest also, but like a what you say is Indian file pattern, which is not seen here. So unlikely it is the lobular carcinoma. Yeah, lobular carcinomas usually have, as I said, epithelioid cells, maybe a little smaller than what we are seeing here. So I think these are the differentials here. Any other differentials you have in mind? So how will you go about it, Shefali? What do you want to do next to prove your point that this is this tumor or
So
that
on
tumor?
on just
Immunohistochemistry,
the
right?
cold biopsy, I can do IHC. We can do
Yes, very good.
cytokeratin.
Very good. I think we'll start with IHC. Somebody said, Kushi said, can it be primary stromal sarcoma? Yes, that can be also a possibility. Usually, that always is a possibility. When you're dealing with something you think could be a metaplastic carcinoma, or it is a malignant phyllodes, or a rare possibility of pure stromal sarcoma of the breast, but they usually are, more periductal arrangement of the cells, that kind of cuffing of the ducts around. That's how usually you get those periductal, uh, those pure stromal sarcoma of the breast. Somebody has said, Maha has said, whether can it be fibromatosis? Yes, it can be fibromatosis. Usually fibromatosis will also have very collagenous or myxoid areas with these spindle cells flowing into it like a fascicles, maybe some long fascicles. They usually will not show you much of nuclear atypia, by and large, will not show you mitotic activity. But yes, you can entertain at least in true cut biopsy, because you're not going to see in true cut biopsy the periphery of lesion, wherein the fibromatosis will have nice infiltration of the adjacent fat or skeletal muscle, and that gives you a clue that you are not dealing with something like a carcinoma, but fibromatosis. But that will be definitely will be a differential at least. So in order to go ahead, we'll have to do markers to prove whether it is epithelial, whether it is stromal or mesenchymal, like that. So we'll start with what, Chef Ali, we'll start with cytokeratin, right?
Cytokeratin, yes.
Okay, let's see. So you have already enumerated everything. These are spindle cells in fascicles, fake fascicles. It's infiltrating between the normal breast tissue and fat. Cells have eosinophilic cytoplasm, mild to moderate nuclear variation. Mitosis were very few, probably, and dense collagenized stroma is there, and some places myxoid. So these are actually so many differentials of the spindle cell lesions, which include spindle cell tumors of the soft tissue also, and the something which you see commonly at this site also, like PASH, nodular pseudoangiomatous hyperplasia, although you don't see such morphology. But just to say, enumerate the spindle cell lesion at the breast, there can be so many things, including PASH, which is seen in breast. What is PASH means? Pseudoangiomatous stromal hyperplasia. Sometimes post FNAC also you can get reactive spindle cell proliferation. I will just, out of this list, I'm just going to say which are the site specific, means breast specific lesions, not the soft tissue specific, because soft tissue tumors can also occur in the breast. But I'm going to talk about only the which can occur in the breast. Then you have low-grade fibromatosis like carcinoma. You have fibromatosis of the breast. You can also get something like mammary myofibroblastoma, somebody mentioned. You can also get something very interestingly, a cellular spindle histocytic pseudotumor, which is actually happens after a fat necrosis. It actually start to look like a spindle tumor. But you will have some areas of fat necrosis, and then around that you will have this very histocytic cells which are spindly. And myoid hamartoma is also one of the differentials. To that list, you can add malignant Pilots tumor, which is having spindle cell morphology. Okay, so we're doing IC. So CK. So is this CK positive, Shefali, or negative?
So
Cells
positive,
of interest. So cells of interest are these spindle cells, right? Which are
yes.
infiltrating into the fat. Everything is positive, nicely.
Positive.
So it is showing epithelial differentiation. So these spindle cells are showing epithelial differentiation, which is cytokeratin. Okay, right? HMWCK, another marker, which is high molecular weight cytokeratin, again,
Yes,
which is
positive.
positive. There are two markers which are positive. We are quite sure now this is something which is epithelial, malignant epithelial tumor, which is showing sarcomatoid morphology, correct?
Yes, sir.
So it could be your first differential.
Metaplastic.
Yeah, very good. Another marker, P63, is
Positive.
also positive, right? Strongly and nicely. It also helps to make that diagnosis. Why we would do P63 in this case? So you have to remember that in some lesions, which if you have, let's say, have a reactive conditions, if you say it is myofibroblast proliferation, which sometimes can look ugly, can have nuclear pleomorphism, some mitotic activity, and then you start to think, oh, myofibroblast can also express CK. So that you have to remember always, the caveats you have to remember, the exception you have to remember. We do CK to prove it is epithelial, but there are tumors which can also express CK, including or the cells which can also express CK, like myofibroblast, reactive. Most often they express cytokeratin. So that doesn't mean it is directly you jump onto the diagnosis of metaplastic carcinoma. So you have to prove it by doing something else. So in this case, at this side, P63 is a very good marker. If once it comes positive, you are very sure that this is a metaplastic carcinoma and not something otherwise you think of something like a reactive condition, like post FNAC, some pseudosarcomatous proliferation, or some fat necrosis related something, sarcoma, myofibroblast proliferation with something like that, a reactive condition completely. So this proves that this is actually malignant, or rather epithelial only, and not something reactive like myofibroblast, which can also express CK with this much intensity. So just remember, you just have to remember some exceptions in biology or in pathology in particular. Okay. So P63 proves the point here. that it is indeed a metaplastic carcinoma. Other markers is 34. Somebody said, could it be angiosarcoma? 34 is negative, although angiosarcomas can be 34 negative. You'll have to do 31 and ERG if you are suspected. I was not suspecting. Here 34 was done actually. Usually if you there is the Phyllodes tumor, the stroma of the Phyllodes tumor can be 34 positive. And especially when they are benign or borderline, you get 34 positivity nicely. The moment they start to become malignant ones and very high grade ones, we start to lose 34, but almost 60 to 70% of Phyllodes tumors will express CD34 in the stroma. So it's a good way to make the judgment by doing the 34 also. Let's see your differential between metaplastic carcinoma and Phyllodes. You may try to do 34. If CK is negative and 34 positive, one may favor one over the other. Okay. ER. So because we have done CK was positive nicely, P60 was nicely positive. Our diagnosis definitely is like a metaplastic spindle cell carcinoma, low grade fibromatosis. Like I will come to that. So you also have to do the breast biomarkers, right? So breast biomarkers, what we do is ER, PR, HER2. These are called predictive markers. You know why we call it predictive, Shefali? We say predictive markers. So what are we predicting here? Can anybody say from the audience also, or Shefali, you are first tried to give the answer. But if you don't know, somebody else can tell.
Prognostic.
No, I am saying predictive. There is a difference between prognosis and prediction. So why I am saying ER, PR, HER2 are the predictive markers. They are also prognostic markers, but we do in all the breast cancers or carcinomas. Yes.
Treatment.
Very good. Yes, there people have been giving the correct answer. So we are trying to predict what treatment it will respond to. So if tumor is ER and PR positive, we know that it is going to respond to hormonal treatment, anti-estrogenic treatment, right? Yes. If it is HER2 positive, then it is going to respond to anti-HER2, like a trastuzumab. And there are other mAbs also which have come. So you start with that. So when we say ER/PR is positive, or HER2 is positive, we are actually predicting that this tumor is going to respond to that particular treatment. That's why we say these are predictive markers. Okay. Prognostic markers are like you are just saying prognosis, how this tumor is going to behave, irrespective of whatever you are going to do. That's also like HER2 is a predictive marker to say it is anti-HER2, it is going to respond to anti-HER2 treatment like trastuzumab. And also it is a prognostic marker because HER2 positive tumors are prognostically bad as compared to only ER/PR positive tumors. So that also gives you prognosis. So this is the difference. So because now this tumor we think is a metaplastic carcinoma, you have to do, because it is carcinoma, you have to do the base biomarkers. It was ER positive negative, PR negative, and it was also HER2 negative. So it is a triple negative tumor. Okay. So the diagnosis here is fibromatosis like spindle cell metaplastic carcinoma, or some people also call it low grade fibromatosis like spindle cell metaplastic carcinoma. And very interestingly, what it was triple negative tumor. The moment you think like triple negative tumor, oh, these are very high grade tumors, you think like that. Triple negative breast cancers are high grade carcinomas, they will behave badly. And nowadays, triple negative breast cancers, if they are of certain size, more than like, let's say 1 centimeter, 2 centimeter, nobody goes and does surgery up front. They will give the chemotherapy first, and then they will do the surgery. But not for this tumor. This is a low-grade metaplastic spindle cell carcinoma. It's not high-grade metaplastic carcinomas, which are also triple negative. But this is a low-grade one, which is triple negative, and here there is no anterior or prior chemotherapy given before the surgery. This tumor will behave better, so they will directly go for the surgery. Okay, so that's the difference. So that's why you have to write whether it's low-grade or high-grade. These are low-grade tumors, so you have to write it is low-grade tumor. Okay. So just to give you something like these are, I just said it is a metaplastic carcinoma having very bland looking cells which resemble fibromatosis, like somebody gave that differential, and that person that student was absolutely right. They resemble fibromatosis like because they have abundant this collagen or a stromal collagen. Very interestingly, they can appear de novo or also in association with papillary lesion. If I, the thing which I had shown you like that intraductal proliferation sclerosing, which I believe is actually a small intraductal papilloma, and probably this was associated with that. So that people have found that some of these can be associated with these sclerosing lesions. They have high propensity for local recurrence, but they seldom go to lymph node or distant metastasis. That's why they behave better. And of course, you have to do IC to prove whether they have epithelial differentiation. And they can be associated some inside to carcinomas also. Okay. I already said, even though they are triple negative, the prognosis is much, much better than the other high grade triple negative breast cancers. And what people believe, the those who do the research, that these are a distinct subtype because these tumors do not share similar genomic alteration with other types of metaplastic carcinoma, which I said like high grade metaplastic carcinomas, grade 3, which are triple negative. So this patient went for after the true cut mastectomy, and this is the section from mastectomy, and it looks like the similar what we saw there. Again, very bland looking tumor having some mild nuclear atypia and lot of collagen at places, almost looking like a fibromatosis. Okay. This was another case. This was in a young female breast lesion. Again, similar looking tumor, very spindle looking tumor. In this, I didn't see any ducts actually, but if you see there is spindle proliferation, hypocellular to mildly cellular with collagenous areas, some myxoid areas. And the eye power also you see very some fascicles here and there. Collagenous stroma looks bland, not much of nuclear atypia, and no mitotic activity. And then again, you have to prove whether it is fibromatosis like carcinoma. That first you have to rule out because carcinomas have different treatment than the other tumors. So you have to prove by doing markers. So CKA1, A3 was negative. So unlikely that it is going to be metaplastic fibromatosis like carcinoma. SMA was focally positive. 34 was negative. Test mean was negative, but beta catenin is nicely positive. There is nuclear positivity also. So it is not a metaplastic fibromatosis like carcinoma, but it is actually fibromatosis. It can occur at the breast. So, the proper histological evaluation as well as proper judiciously used IHC will help you to make the proper diagnosis. Another case, just I'll go through 2-3 cases just to prove the point. At the breast side, when you see such morphologies, what should come to your mind and what thing you should see to make the diagnosis? Sometimes even you go wrong just on a true cut. And you see something else in the mastectomy. So this is a 56-year-old female. She had a 5 centimeter size palpable lump and needle core biopsy was done as usual. Nowadays, nobody does FNAC, and FNAC should not be done. If your surgeon is doing FNAC for breast lump, you have to tell them you cannot do FNAC these days. Please give me biopsy. So, because it's very important. One is biopsies. We are very confident making the diagnosis. Other thing is you can do the breast biomarkers, which are like I just told you, predictive markers for to decide the treatment. Sometimes the treatment can be upfront surgery. Sometimes treatments can be upfront chemotherapy followed by surgery. So it's very important that we get a biopsy and then on that you do the markers to help them making the clinical decision. So this is a true cut biopsy. What you see is very cellular tumor at this power. There are this fragmented tumor, but very cellular looking. And then there are some areas where benign ducts is there surrounded by this collagenous stroma. And here there is something which looks quite highly nice with some calcification in between. I'll come to that later on. And then you see this tumor, it has got epithelioid as well as some spindle cell morphology. Very cellular looking here also. Looks blue. The moment you see anything looks blue, then you have to think that it has got high NC ratio and it's quite cellular because then there is not much of cytoplasm there. If you have more of cytoplasm, it will look pink. It looks rather blue. And then this hyalinized area, can you see there is like some lift-like pattern or intracanicular-like pattern is there, although the stroma is completely hyalinized. It suggests that this area is actually maybe some very old
यार थोड़ी देर में
hyalinized,
आई
very hyalinized fibroblastic tumor was there, which is completely now hyalinized and has even calcified. And then you have this tumor here, which is cellular looking. You go on high power, there is definite epithelioid to some
मैं अंदर
spindle cell
बैठी हूँ
morphology in some areas. and there is a definite nuclear atypia. There are some osteoclast-like giant cells thrown in between. And then you go upper hyper, you start to see some mitosis, including one this atypical mitosis. Multiple spindles are there, there are multiple poles, and some mitosis here and there. Nuclear atypia is there, some osteoclast-like giant cells. So it looks malignant tumor definitely. Has got this spindle and epithelial morphology, very pleomorphic looking. And then obviously differential will be whether it is a metaplastic carcinoma or whether it is a malignant Pilot's tumor. Okay, so you do the markers again to prove the point. So cytokeratin A1, A3 was negative. CD34 is negative here because I told you spindle cells of the Pilot's tumors can be positive, but it came negative here, so it doesn't help me. P63 is actually is positive in good proportion of cells. I would say 20%, maybe 15 to 20% is positive. So even though CK is negative, P63 is positive. I said you do it in a combination, even if one of them is positive in the correct setting, in the correct histology, you can say it is metaplastic carcinoma. So here P63 positivity is tilting me towards making the diagnosis of metaplastic carcinoma. Some EMA positivity here and there, maybe there are some plasma cells also, not very sure, but most of the cells are negative. But SMA is positive. Again, I said SMA can come positive in metaplastic carcinoma, but similarly, even malignant phyllodes, which has got differentiation towards muscle, can show is SMA positivity, right? So SMA doesn't help here, SMA is positive. CK8 by 18, another cytokeratin. I said you don't stop at one cytokeratin, then you do another, which is negative. And then I pushed in CK56 also, and CK56 did show some positivity in this area, and it's a good positivity. So based on, and then Desmin was negative because Desmin was positive. Desmin is also is done. Desmin was negative, 34 negative. So considering that there is P63, some CK56, one cytokeratin, one P63 also to prove that it's epithelial. Considering 34 is negative, and I favored that this is a high-grade sarcomatous tumor, favor carcinoma. This is very old case, and in those days, the people usually used to opt for whatever this the surgery up front. There was no concept of anti-chemotherapy. Probably if today, if I make this diagnosis, for carcinoma, they would go ahead and treat it like a metaplastic carcinoma, give chemotherapy, and then do the give chemotherapy for carcinoma, and then do the surgery. But this time, in this because this old case, they went ahead and did the mastectomy. To my surprise, the mastectomy had this fibroblastic tumor along with this tumor which I described, which was seen in True biopsy, very malignant tumor, sarcomatoid or pleomorphic, and then you had this phyllodes, which has got, how do you say it is phylloid? Because it has got very exaggerated intracanalicular pattern or leaf-like pattern, very heterogeneous morphology, subepithelial stromal condensation. And then you have this tumor, along with that there is this malignant tumor also. So this was not a carcinoma actually. This was phyllodes only, which has got this very dedifferentiation or high grade phyllodes, which can show you all this. And in some area there was this chondroid differentiation also. So phyllodes can show you chondroid, osteoid, angiosarcoma, anything. It can show liposarcoma. And that was the area. This was more undifferentiated areas, which was looking very high grade pleomorphic sarcomatoid, which showed some P63, some CK56, which led me believe on just True biopsy that it was I would favor carcinoma over a phyllodes, and that's what I had done. But mastectomy is showing something completely else picture. So once you have a fibroblastic tumor along with this malignant tumor in between, then this is definitely malignant phyllodes and not the carcinoma. Okay, tumor is so matrixically active. You can see the nuclear pleochroism so well in the mastectomy specimen. And probably the clue in the biopsy was this highly nice fibroblastic tumor, which we may have said, like I may have said that time that yes, CK expression does favor carcinoma, but because of there is some highly nice portion of a tumor which looks like fibroblastic tumor, this could still be a malignant tumor, and probably that could have sufficed in this day and age. Probably you will have to give such a report, so that probably they will have to go take better biopsy if they were contemplating chemotherapy first. And if they are not, they're anyways going to get surgery, then they can do surgery and we'll be able to make the diagnosis with confidence. Another case also had very pleomorphic looking morphology and very high grade tumor, spindle and pleomorphic cells, lot of mitotic activity. There are some lymphocytes sprinkling between bizarre cells, multinucleated. Definitely same differentials will be there, whether it's sarcoma, whether it's malignant phyllodes, whether it's metaplastic carcinoma. And there are areas which show this chondroid matrix also. But in some areas you see this was actually an excision. So in some areas you see this DCIS with choroidal necrosis here and fibriform areas. So it proves the point that since there is an in situ carcinoma there, whatever this pleomorphic or spindle looking tumor is, it is actually a metaplastic carcinoma because there is a precursor lesion which is an in situ tumor there, in situ carcinoma there. Whatever the IC markers will be shown in this tumor, whether there is cytokeratin negative or anything, still it is, you can make the diagnosis of metaplastic carcinoma confidently. So that is also a good way of doing it. When you deal with excision, you don't see areas like phyllodes or don't see areas like in situ. It is better you go back to specimen, take multiple sections and see if you can see these areas. The moment you see papillary tumor, phyllodes-like areas with this very high-grade tumor, this is malignant phyllodes. The moment you say something like DCIS or intraductal carcinoma, and then you have this very high-grade spindle or pleomorphic tumor, this is a metaplastic carcinoma. So it helps, even if your IC with may not help. So that's the how one should approach such cases. So let's go to, we still have two more cases. So final diagnosis for the last case was a metaplastic carcinoma. The before that was malignant phyllodes tumor. So okay. So case 4, 70-year-old male, biopsy from peritoneal mass. Patient also has got ascites and multiple peritoneal nodules. So who wants to take this? Anybody? Is Sajli back? Sajli was supposed to go out and come back. You want to take this, Sajli? Is she there? Or maybe Sagar?
Sajli, you there? Sagar can, okay, Sagar, try. Hi, Sagar. I can see Anugrah and Shifali.
Anugrah, you want to take it? You did very well with the first case, so maybe you can do it. Come on.
Unmute yourself. Unmute.
Yes, sir. Sir,
Okay,
this is
fine.
again a true cut biopsy.
Very good.
So showing the cells arranged in loose fascicles.
Yes.
They are intersecting also of fat, fibroadipose tissue is also present in between.
Yes.
In this part, sir, I can appreciate only those spindle cells and loose fascicles
Yes.
in between.
Yes, correct. In this area, you see more collagen, right? So this is more
Collagenous. Yes, sir.
collagenous hypocellular area. Then there is mildly cellular or moderately cellular area,
Moderately
right?
cell. Yes.
In this area, you can see even this power, you see nuclear pleomorphism. Okay.
Yes.
So we'll go to another area. This now see this. And you very
This
rightly
is
said there are loose fascicles of the spindle cells, and there's stroma also in between. So mild to cellular. But you can see there is nuclear pleomorphism, right?
yes. Sir.
Very good. What about this?
So this is again showing pleomorphism in the cells with
Very good.
some having hyperchromatic nuclei.
Yes.
And so pale eosinophilic cytoplasm is there. Eosinophilic cytoplasm is there, and
Good. Very good. Now this area. Again, same thing.
same.
There is nuclear
Yes.
pleomorphism, very irregular nuclei. There is some stroma in between, but definitely looks like there is RTPI in this. It looks tumor with RTPI. So maybe there is some mitosis probably. I'm not very sure. But yes, again, some areas showing little more cellular, maybe moderately cellular, and RTPI there. Correct?
Yes. Sir.
Maybe some cells look here. Is this cell maybe have some vacuolation or something?
Right.
Probably. Probably like that. You may think like that, some accumulation within the cytoplasm here also like this. Okay.
Yes, sir.
And here cells, as you very rightly said, they are infiltrating between the fat cells, but they are spindle. And you see here, this looks like a mitosis.
Mitosis. Yes, sir.
So there are mitosis sprinkled in between also. So again, same thing. It's a spindle cell tumor, right?
Yes, sir.
Then you have weak fascicular or haphazard cellular arrangement, which you rightly said. There are cellular and some collagenous hypocellular areas. Nuclear polymorphism there is some mitotic activity. So now this is a peritoneum, right? So
Yes,
what
sir.
will be your differential at this site? So intra-abdominal peritoneal base sarcomatoid tumor, which we think is a malignant tumor or spindle cell tumor. What will be your differentials? I think audience can also give the differentials.
Yeah, they can write in the chat box.
Yes, they were writing. Some of them were very nicely putting the differentials. Yes. Okay. That is, I will only give. So here we will think of whether we are dealing with something like sarcoma, like inflammatory myofibroblast tumor. Possible. There were few inflammatory cells also. Could it be dedifferentiated liposarcoma? I showed you some cells which has got vacuoles. Possible. It has got like multiple nodules in peritoneum. That kind of thing liposarcoma does, So this is a possibility. Can it be GIST?
No, sir.
Why you say no, Sagrika?
Just can be. Just
You are right in saying that because I mentioned already, GIST usually doesn't show this much of nuclear polymorph.
Yes, sir.
Usually, by and large. Rarely you may see. So that can be differential, maybe lower down, but I have put it there because GIST can also present like multiple nodules. Okay.
Okay,
Can it
sir.
be sarcomatoid carcinoma with like mates to the peritoneum from somewhere it is coming, producing like multiple nodules? Maybe possibility. That can be a possibility because sarcomatoid carcinomas can arise in any organ, like even pancreatic biliary here. You can have, so that can also give rise to metastasis like that. We don't know we don't have that history, but it is a possibility, although rare, but it's a possibility. Sarcomatoid melanoma with metastasis to peritoneum may be a possibility, quite rare, but can happen. And then you have sarcomatoid mesothelioma. Can it be? Anugrah, Shefali, can it be? It
So
can be because
could be, sir,
Yes.
but
could be very much likely. So these all there are possibility. Okay, somebody in the chat box said fibromatosis. Fibromatosis usually doesn't show you this kind of nuclear pleomorphism. You saw that case of fibromatosis where they look quite monomorphic, banal proliferation with very relatively monomorphism you see, and then you have this collagenous area, and then you can have long sweeping fascicles like that. So less likely fibromatosis, but you may think like that. Okay, so then you will do the IC, correct?
yes.
So I have done all these markers first, means to show you what were the negative. ALK D5F3, yes, myofibroblast. Yes, we thought of inflammatory myofibroblast tumor. Yes, ALK D5F3, ALK is done for inflammatory myofibroblast tumor. Along with SMA, it can express ALK also, right? So ALK is negative, SMA is negative, desmin is negative. SMA, desmin both together means there is not a muscle or myogenic tumor. S100 negative means it is not something neural or melanocytic. 34 is negative, that doesn't, it means it is not a fibroblastic like somebody thought. Fibromatosis, even 34 comes positive in GIST also. 70% of GIST will express 34 along with CKT and Doggett. So all this negativity rules out GIST also. MDM2 CDK4 negativity rules out what tumor? Anugrah.
Raveen, there is a question in the chat box,
Yes.
and there's somebody called MM wants to know, sir, why did you put sarcomas including inflammatory myofibroblastic tumor? How can be inflammatory and sarcoma be differential together?
No. So inflammatory myofibroblastic tumor is a type of sarcoma. Because these sarcomas have inflammatory cells sprinkled in between, once upon time, actually people used to call them plasma cell granulomas because you see sometimes a lot of plasma cells in them, you know. So that was a misnomer. Later on, with the behavior and everything, we found out these are actually sarcomas or mesenchymal tumors and not inflammatory lesions. So the name is inflammatory myofibroblastic tumor. It is not a inflammation, but it is a tumor. It is a mesenchymal tumor or a sarcoma. Does that answer?
Perfect.
So MDM, yeah. So MDM2 and CDK4 are markers to rule out liposarcoma. So in this case, would be the correct. So dedifferentiated liposarcoma, which we ruled out. P63 again was done along with cytokeratin. That's why probably it was put there, like sarcomatoid carcinomas coming from maybe let's say kidney or maybe urothelial tract. Like urothelial carcinomas also express P63. So that was also negative. But cytokeratin is nicely positive, A1, A3. Okay. And EMA is also positive. So what does that tell you now, Anugala Shefali? What are the differentials? We had these differentials.
Sarcomatoid carcinoma.
So which are the sarcomatoid carcinoma and which other tumor can express these markers, CK and EMA, among these differentials? Yes, carcinoma, sarcomatoid carcinoma, and others mesothelioma, sarcomatoid. So these two differentials, right? Because of these markers, now we have these two differentials remaining, whether it is sarcomatoid mesothelioma or sarcomatoid carcinoma, correct?
Yes.
So CK is positive, EMA is positive. CK7 is also positive. Again, same thing. Sarcomatoid carcinoma versus mesothelioma will have these expressions. So you will do the mesothelial markers. Now BAP1 is lost in mesotheliomas, right? This is a new marker which we do. Loss of BAP1 means mesothelioma, but BAP1 is retained. So can it still be mesothelioma?
No.
Yeah.
Shefali says no. Sagarika, what do you say? Yes or no?
No.
Arpita says no. Sagarika says no. Anybody else in the audience they can write in the chat box. Can it still be a mesothelioma? Actually, answer is it can still be mesothelioma because BAP1 is not lost in 100% of the mesothelioma. In fact, it is only lost in 40 to 50% of the cases. It will differ from the different studies, but not all are so. BAP1 still is written. You can still have a mesothelioma. You will have to still do the mesothelial markers to prove whether it is mesothelial or not. BAP1 is a good marker when you have a differential of reactive mesothelial proliferation versus mesothelioma. You can have such situations. Therein, loss of BAP1 will automatically prove it is malignant proliferation. That is a mesothelioma. Okay. So it is in a situation, it is a very good marker. Here also loss would have definitely proved that it is mesothelioma, but unfortunately it is retained. So you still have to do the other mesothelial marker. Now BARP4 is a cytokeratin marker, which you usually say comes positive only in carcinomas and not in mesotheliomas, but here it is negative. So to say it is carcinoma, it is negative. So could it still be a mesothelioma? Okay. So calretinine is positive. See calretinine. Again, calretinine is just like a S100. You have to see not only cytoplasm but also nucleus. So good number of cells also showing nuclear positives. So calretinine is positive. It's one of the mesothelial markers. You just don't. Again, I told you if you have IHC, you just don't stop on one markers because calretinine can often come positive in some of the carcinomas like lung carcinomas, and there are other carcinomas also. So you just don't stop at one marker. You will have to do at least two or more to prove that it is of that certain lineage. Let's say mesothelial. So with calretinine, you have to do WT1, CK56, D240 to prove it is mesothelial. At least two markers should be positive. Similarly, when we say something is neuroendocrine, then you just don't do only cyanotoxin because cyanotoxin can come positive in Other tumors also. So you just don't do cyanotoxin, you do cyanotophysin, you do chromogranin. If needed, you can do CD56, you can do ANSM1. So you prove that there are two markers positive. That is then of that certain lineage. Okay. So calretinin is positive, CK56 is also positive. D240 is positive in few of the cells, but it is positive. If you see this cell is nicely positive. And WT1 was also positive in some of them. WT1 again is you have to check in nucleus. Nuclear positivity is considered positivity for this mesothelium, or for let's say something which is like a serous carcinoma of the ovary. Or so the WT1 positivity in mesothelium and like that carcinoma, you have to prove that it is in the nucleus, even in like a chick duct sarcomas in the children, So it's a nuclear positive. Cytoplasmic positive doesn't carry meaning. Although some of the tumors have been shown to show cytoplasmic positive WT1, like uh, your smooth muscle tumors and other tumors, but that is not a diagnostic thing. It is just seen like that. So here some of the nuclei does positive, so nuclear, so it is positive. So it is a sarcomatoid mesothelioma. Okay. So when do we say sarcomatoid? When you say that more than 90% of the tumor has got sarcomatoid areas only, and very few epithelial areas, like because mesotheliomas can be what? Three types: epithelioid, sarcomatoid, and biphasic. That means both, like epithelioid and biphasic. So if you have to say anything sarcomatoid, you have to have morphology sarcomatoid in more than 90% of the tumors. And you say desmoplastic type of sarcomatoid when you have desmoplastic areas. That means completely collagenized tumor in more than 50% of tumors. Then you say desmoplastic mesothelioma. Those are rare ones, but very difficult to diagnose, especially they occur in the pleura. Similarly, most of the sarcomatoid mesothelioma occur in pleura. Outside pleura are actually rare ones. And in fact, the sarcomatoid mesothelioma as such, as a type, is a rare type. Is a 10% of all the pleural mesotheliomas. Only 10% are sarcomatoid, and they mostly occur in pleura and outside pleura. Like this is peritoneum, is extremely rare. Only 2 to 3% are sarcomatoid, purely sarcomatoid. Now this is a true cut biopsy. So maybe there are some areas in the tumor somewhere there epithelioid morphology, you don't know. But whatever true cut was seen, it is showing sarcomatoid morphology. So we'll go to case number 5, last case. A 52-year-old female, a true cut biopsy of large pelvic mass. The moment we say pelvic mass, then you should think like it could be coming, if it is female, it is ovarian tumor, right? So that's how we think. So, or ovarian, or maybe from the uterus, but most likely ovarian. So CT guide finding was that it was a 15 centimeter size mass in the pelvis, was inseparable from ovaries, and there were multiple peritoneal deposits, and CA125 was rare. It was not like more than 1,000, but it was in few hundreds. So that's the history. Who wants to do this? Anybody? Quickly. We are already 9 o'clock here. Anybody? Sagrika, you want to take? Quickly, you just have to describe what's the pattern, what is this tumor looks like. That's it.
So the given from the given biopsy, the pattern looks
Very
walled
good.
appearance. The spindle cells are arranged.
World, or
The
you
blood
want to say from the center, they are like pokes going around.
The story for
yes,
Storiform pattern. Excellent.
partly lipid.
So it is actually a storiform pattern. Very good. That's a very good observation. So it's a spindle cell tumor showing this very nice storiform pattern. And in at places, it is little haphazard also, right? Like this area is more haphazard. And there are these vessels which has got some halinous walls. Okay. In other areas, now what you see, this area, does it look like a spindle here?
Mm.
This they look more rounded nuclei, right? So it could still be spindle if you cut it like that, the cross section transversely, then the spindle cells will also look like a round cells or epithelioid cells. So basically here you see spindle cell type morphology. Down also you see spindle cell morphology with this nice storiform pattern which you rightly saw. In some areas, it does have epithelial morphology. Maybe it is a cross cut or transverse cut. That's why you see like that. But this is what we say story from. In the from center, the spokes comes out from the center. That's what we say story form pattern. Okay.
Yes.
And the spindle cells have some nuclear atypia, but they rather still look so monotonous, I would say. And then this area again, this epithelioid appearing area, probably, or maybe transverse cut. In high power, again, the cells look quite. There is some nuclear pleomorphism, but you don't see a mitosis. Maybe mild to moderate, mild nuclear pleomorphism, I would say. But mitotic activity is not there. In some areas, you see this myxoid stroma also, right?
Yes.
Here you can make out these are definitely spindle cells because they have tapering hands. They are broad in the middle, but not much mitotic activity. Some nuclear pleomorphism, not much activity. Maybe there is an occasional mitosis here. Some small cells here and there, they're like maybe in lymphocytes, right? Some lymphocytes sprinkled in. Again, spindle cell morphology, storiform pattern, some collagen in between stroma, some occasional mitotic figure, but it's not rip-roaringly mitotically active. It's not have that much of nuclear pleomorphism also. Okay, so what will be the differentials? Now again site, remember the site and the age of the patient, and then try to formulate the differentials. UPS, undifferentiated pleomorphic sarcoma. Undifferentiated pleomorphic sarcoma, the name suggests that it's very pleomorphic, very undifferentiated, very high grade. Unlike, no, this is not that kind of tumor.
Fibrothecomas.
Yes, very good. Somebody says ovarian fibrothecoma or ovarian fibrostomal tumor. Correct. Fibrosarcoma again will be more cellular, more mitotic active. And fibrosarcoma and ovary are very, very, very rare. So more is a fibrothecoma kind of tumor, which is we say stromal tumor, right? So stromal tumor of ovary is an excellent thought. Any other thought? Let's say it's not an ovary, it is just a pelvic mass with peritoneal nodules. Then what can be anything? Leiomyoma, Mugdha says leiomyoma or leiomyosarcoma, I don't know. It could be leiomyomas to say that, usually if you remember this smooth muscles cells, they have very pink cytoplasm, very dark pink cytoplasm. This tumor doesn't have that dark pink cytoplasm. The nuclear elongated having tapered or the rounded edges. It's not like that. Gist is a very good option. Arpita says gist. Gist is a very good option because you see this tumor. Tumor is still very banal or monomorphic with very mild nuclear decay. Occasional mitotic activity. It's not like very high grade sarcomatoid tumor. It's in that sense it looks low grade. So gist is very good differential. Gist can have storiform pattern. Gist can have fascicle. Gist can have haphazard pattern. They can have palisading also. That is a very good option. So yes, gist is an option. Stromal tumor of the ovary is an option. You can have low grade, maybe mesenchymal tumors. Leiomyoma less likely, but okay, maybe some fibroblastic tumor. Okay. You may say there are some lymphocytes are there, not many plasma cells, but somebody may say I'm FT. Okay, because this is true cut biopsy, you still have to consider that possibility. So basically, these are what are the differential. If you say this spindle cell tumor, I already mentioned monotonous looking cells with minimal neotropia, storiform pattern, vague fascicles. Some areas it does have some epithelioid, maybe occasional mitotic figure. So these are the differentials one would absolutely right. You have given correct differentials. Sex stromal tumor of ovarian origin, gist maybe extra intestinal or sometimes very rare possibilities of gist in the ovaries are also there, very rare. You always think when your tumor doesn't fit into, let's say you get a ovarian tumor, it doesn't fit into any of the usual tumors of the ovary, then you have to think laterally, think anything whether it can resemble. If you think it is resembles, you have done all your markers, you don't know what it is now, then you think laterally whether does it resemble something which is not seen in ovary, like a gist. Okay, it could be gist. You can have pseudopapillary tumor, like those who occur in pancreas, we call it pain. They can also occur in ovaries. You can have SFTs in the ovaries. So, anything can occur, but you have to think outside the box if it doesn't fit with the usual morphology and usual immunomarkers are negative. Then only. So just extraintestinal or could be from ovary, who knows? And low-grade spindle cell mesenchymal soft tissue tumors. These are the possibilities. So we'll do the markers, right? So cytokeratin is negative. Now
Negative.
cytokeratin may be epithelial differentiation, but I told you some stromal tumors or sex cord tumors all can also be CK positive in the ovary. But that is also negative. That rules out that possibility. But EMA is positive. Can it be epithelial still with only EMA positivity? So less likely because most often you have to have CK also. So just remember, EMA can be positive in so many tumors, but CK comes mostly in few of the tumors. So that is how you treat. So in a given a situation, EMA just EMA without CK less likely epithelial. Inhibin for stromal tumors is negative. Another marker, you just don't stop at one marker, I said. So you will do other markers, calretin, inhibin, calretin, both are negative. CD56 also marker for stromal tumors, which is also negative. Only few, some histiocytic or dendritic type histiocytes, which are positive, but tumor is negative. So there are three markers done to prove it is stromal tumor of the ovary. All are negative. So unlikely it is stromal tumor. SMA, somebody said, Kushi, I think said, Leo, whether it is smooth muscle. Okay, that can be possibility. Let's say some myxoid may not show so dark eosinophilic cytoplasm. Some myxoid, small vessel tumor. Okay, we'll entertain that possibility. But SMA is negative, desmin is negative. So that is also, it is not a smooth muscle tumor.
Leomyoma.
Yes, leiomyoma or leiomyosarcoma, whatever you want to consider. If you are considering these possibilities or stump, those are not there. 34 is negative. I said fibroblastic tumors, those are usually positive. That is also negative. Yes, 100 is also negative. You thought it is low-grade some mesenchymal tumor, maybe Naushet tumor or something. That is also negative. So all these markers are negative, right? CKIT for GIST is negative. Only few mast cells are positive here and there. You see, most of the spindle cells, like smooth muscles or even like stromal tumor, they do have some mast cells negative. That acts like your internal control also. So CKIT is negative. Dog1 is also negative. Both are marker negatives. Unlikely it exists, right? Whenever CKIT negative GIST are there, they are going to be dog1 positive. So both are negative, very, very unlikely it exists. Okay. So what we have ruled out here, sex cord stromal tumor, we have ruled out. You have ruled out any odd looking epithelial tumor, whatever. It doesn't look like anything. But let's say you have ruled that out. Any tumor showing epithelial differentiation. GIST you have ruled out. You have ruled out mesenchymal tumors which are of myogenic, neural or fibroblastic type, right? Now here you have to think out of the box. That is what I was trying to say. Spindle cell lesion, but out of the box. So we thought out of the box and did the markers, these markers. CD23 is positive. CD23 again another area is positive, and CD21 was positive. So CD21 and CD23 both are nicely strongly positive. So what is your diagnosis now? Can anybody say what are these markers for? We do it usually in lymph node, lymphoproliferative neoplasms. Sometimes we do these markers. So what these markers mark? 21 and 23 with this kind of morphology. Yes, very good. Mugdha and Simran both have said dendritic. Yes, these markers mark follicular dendritic cells. And this is the tumor of those cells. So what is the diagnosis then? Follicular dendritic cell sarcoma. Okay. So not only carcinoma shows spindle cell morphology, not only mesothelioma, not only melanoma, and then the spindle cell tumors of the soft tissue, but even the dendritic cells can also show follicular, this spindle cell morphology. Okay. And this is rare tumor, but in certain situation like this, you will have to make appropriate immunohistochemistry to rule this option as well, because they can also occur outside the lymph nodes in other areas also. Even in soft tissue also you get FDC sarcoma. So high suspicion should be there. Now, because this patient had multiple nodules, they gave anterior chemotherapy. Mugdha wants to ask something. That's okay. Anyways. pelvic mass, they give chemotherapy and then resected the pelvic mass. There were large areas of necrosis, maybe related to chemotherapy. There was no origin with this. So probably it was something in the soft tissue, this. And then this time tumor looked, there it was looked more spindly with very focal epithelial area. Here it looked more epithelioid, having this very thin wall vessels. And again, if you see there, we're quite monotonous looking. Here now the nuclear chromatin looks rather open or this thing with nucleoli. And this is actually the morphology one should remember. And you can have some sprinkling of small lymphocytes. Usually you have small sprinkling of lymphocyte with this morphology, very monomorphic looking, little mitotic activity, little nuclear pleomorphism. You should think of, this follicular dendritic sarcoma once you have ruled out other possibilities. You do the appropriate markers. See the sprinkling of lymphocytes. And I still remember Madam Borges, Dr. Borges, Madam used to say that this tumor usually have only sprinkled lymphocytes, they never have plasma cells, which is a very nice clue. Afterwards, when I saw a few of these cases, although these are rare, they usually have only lymphocytes and no plasma cells somehow.
And
That is
Praveen,
one.
this is not described in literature anywhere. What Anita said.
What Madam had described, yes, sir. I think
Nowhere in the literature. Only
maybe we should write it, sir.
Yeah.
So this is a FDC sarcoma. Thank you, sir. And so so you think of this possibility also. So I have given you with all these cases, and again this resection had 21-23 is proved. You have to think of this differential at some sites, and put this more immunos to prove this point. Just to give you in a short that these follicular dendritic cells and reticulum cells, which are we call it SERCs, cytokeratin positive reticulum cells, actually come from mesenchymal cells. They are not from myeloid stem cells. So myeloid stem cells then give rise to other cells like monocytes and whatever, with including Langerhans cells and plasmacytoid dendritic cells. But these follicular dendritic cells actually come from mesenchymal cells and not from myeloid cells. And then you have the tumors which are coming from there. So let's say from follicular dendritic cells, which are mesenchymal origin, they give rise to follicular dendritic cell sarcoma. You can also have what is called a EBV positive follicular dendritic sarcoma, usually occurs in spleen in immunocompromised patients. And then also you can have follicular reticular cells tumors also. And these other tumors which are like a histocytic tumor, not from stroma but from the mononuclear phagocytic system of a myeloid precursor origin. Then you can have those juvenile granthosannuloma, Ardine Chester, Rosa Dockman, and all those tumors. And of course, LCH is also part of those tumors. What can be sarcomatoid in this histocytic dendritic tumor is this tumor, sarcoma-like, which is interdigitating sarcoma, histocytic sarcoma, LC. Langerhans cell sarcoma usually don't have that much spindling, but sometimes you can have spindling when they are sarcoma. I'm not talking about LCH. LCH is a different, but these are Langerhans cell sarcoma, not Langerhans cell histocytic. And of course, follicular dendritic sarcoma can look like a sarcoma. Just to give you something shortly, that when we use broad spectrum IHCs, like let's say epithelial markers, like CK or EMA, but any sarcomas which are called epithelial morphology, even leiomyosarcomas for that matter, can express cytokeratin. So you doesn't stop there. Your histology has to be good. Like if you think anything is like a smooth muscle like, then even if you get some cytokeratin, you have to do sesame, desmine, H-paldosman to prove it is smooth muscle. So like that. So even broad spectrum tumors can have expression outside their usual sphere. Like EME comes positive even in plasma cells. I showed you. It can come positive in ALCL, DLBCL, and so many other tumors like NLPHL and FDC sarcomas. Melanomas, some of the melanomas can be keratin or keratin positive also. So you have to have high suspicion on your histology based on your site of the origin of that lesion and the clinical history. Then only you interpret all these markers. Just interpreting markers is not good enough. Like let's say melanoma like S100, I said. S100 comes positive in 10 to 40% of the carcinomas, especially at salivary gland, breast, and cutaneous sites. So just doing this 100 and saying it is melanoma is not good enough. You'll have to do then markers like CK, different types of CK or EME. SOX10 also come not only in melanomas or neural, but also shows tumors with myoepithelial differentiation. Melanae, which is marker for melanoma, also comes, as I showed you, in SOX-called stomal tumors. Can come in adrenocortical tumors, can come in translocation RCCs, clear cell sarcoma. So there are so many tumors. You just have to remember that, sometimes even these broad markers, which you use for making a diagnosis, confirming the lineage of the tumor, can also positive in some other lineage. So it is not just one marker. It has to be a panel of the markers. Like in hematolymphoid markers, like 138 we do, more than 40% of the carcinomas or epithelial lesions will be positive or 138. So let's say in a small biopsy, you think something looks like the plasma cell neoplasm. You just do 138, it is positive, that doesn't mean plasma cell neoplasm. If you have any suspicion of that, it could be epithelial or carcinoma, then you have to do CK, EM, and other markers. MUM1 is a very good marker for, as I mentioned, for proving it is something of like a lymphoid tumor, right? But it is almost always expressed in melanoma, especially epithelioid type melanoma, not the spindle cell ones. So you just have to remember all these caveats, all these exceptions, so that you become a good histopathologist. Okay. So to summarize, spindle cell lesions or tumors can be many. I mean, most of the soft tissue tumors have spindle cell morphology. Okay. So like when we say sarcoma, what come to our mind, that spindle cell morphology. But again, remember, there are spindle cell, there are mesenchymal or soft tissue tumors which have got epithelioid morphology also, right? And many spindle cell tumors can have a variant which is epithelioid variant. Just to give two examples, malignant peripheral nerve sheath tumor is a spindle cell tumor, but there is a variant called epithelioid MPNST. Leiomyosarcoma by and large is a spindle cell tumor sarcoma, but there is a variant called as epithelioid leiomyosarcoma. So mesenchymal tumors having spindle cell morphology can also show you epithelioid variant, or there are mesenchymal tumors which will have only epithelioid morphology, like carcinoma. Similarly, as I showed you with the examples, like carcinomas which have got by and large epithelioid morphology can at sites have a spindle cell morphology resembling sarcomas, but they are still a carcinomas. So again, histology is important, and judicious use of IHC is very, very important. I hope you must have got some pointers in these different cases. And with that, I will stop now. Thank you so much, students, for attending it and participating it. And there are quite a few from the audience also. They were also participating it, and it was really nice. So thank you so much, and thank you so much, moderators, also for doing this job. So thank you.
Thank you,
Thank
sir.
you, sir.
If
Thank
there
you.
are
There are
any more questions, then maybe if there is time, I don't know if there are people are there. I can answer it if there are any.
I think moderators will know. Are there any questions? I've seen many questions on the way, but I think you addressed mostly.
Yeah,
Right
it's
now, I don't
already
see any.
done. Yeah.
Most of
I
the
think
questions you have answered in between the sessions, sir.
Marathon sessions, Praveen, marathon session, and still we have 70 around 70